Uh, Welcome, sir. Good morning. So, good morning, everyone. Welcome to today's episode on cardiopulmonary series workshop. Today we will have the second module of the cardiopulmonary workshop, which is heart on cardiovascular assessment, and it will be done by Dr. Babatunde Ogundumadi, Director and HOD of Physiotherapy Department, just Jos University Teaching Hospital, Jude. You are welcome, sir.
Okay, good morning, everybody. Good morning, everybody.
Good morning, sir.
You are all welcome. Sorry for a little delay. I had a little network challenge over here, but I have been able to overcome that. I welcome every one of us on board to this long training today. It's so much simplified. You'll be able to understand everything. And after the presentation, after the workshop today, you'll be able to have the material to go home with for further studies and reference purpose and evidence also for your participation in this particular workshop. I hope you are seeing my slide. Are you seeing my slide? Are you seeing my slide?
Yes, sir. We are.
Yes, sir.
Okay, thank you very much. So, like our moderator has said, we are into the second module today of the series on cardiopulmonary workshop. And this particular one is going to be on heart and cardiovascular assessment. Heart and cardiovascular assessment. Like I said, it is so much simplified that you'll be able to understand everything that we are going to go into with your paper to do some jotting and to be able to answer some questions if need be as I go on in this workshop today. And I also want to say that at every 30 minutes, I'll be punctuating the class so that you'll be able to stand up and stretch yourself so that we obey the law of ergonomics. We are also into some cardiopulmonary, and we know that there's need for circulation of blood. We don't need to sit for too long in a place. So you are welcome. It's intended that through this workshop, you'll be lifted up from the level you are now in knowledge as pertaining to this heart and cardiovascular assessment to the mountain top to another level. This is the synopsis of the lecture that will be delivered today in this workshop. We go through the structural and anatomical and physiological and clinical details on cardiovascular system. It's actually going to be detailed. It's going to be well explored. Like I said, simplify. We look at the heart. We look at we look at some heart conditions and the heart disorders. Then we'll delve into the causes of heart conditions and heart disorders. We look at the predisposing factors to heart conditions, signs and symptoms of heart conditions and disorders. Also, we try to explore into the cardiac contributions to brain health. Then we explore the diagnostic tests in cardiovascular conditions, vis-a-vis outcome measures. Many of them actually are going to be explored in this presentation. I'm going to have them as take home, and you are going to be able to apply it on your field as you come across this patient. Then we'll look at the assessment and examination of cardiovascular system, then the precursors to exercise prescription in cardiovascular conditions, and how we can optimize exercise prescription rehabilitation programs. Then the prognosis would go on and then the practical demonstrations and hands-on session for the people on ground. So this is the lecture objective. We want to explore the structural, anatomical, and physiological details of the heart and cardiovascular system. We want to understand the heart condition and heart disorders. We want to understand the cardiac contributions to brain health. We want to understand the diagnostic tests in cardiovascular conditions, and to also be taught in this workshop the comprehensive assessment as an examination of cardiovascular system. Furthermore, we seek to focus on the precursors to exercise prescription, and we also focus on understanding on how to optimize exercise prescription. We'll probe into the scientific world and see this evidence behind our physiotherapy intervention, a lot of evidence really. And we want to begin to look at some scenario of looking at cases of patients, maybe in some video form, and we'll begin to see what are done concerning them. And practically, lastly, some questions I'll be asking you for some demonstration. When we talk in terms of cardiovascular system, we look at the heart, we look at the blood vessels, we look at the blood. It's actually a closed system that performs three main functions. We have the function of transportation, the function of protection, and regulation. As for transportation, the things that it transports, they are not human beings, as in the colloquial sense of transportation. We have nutrients. It transports nutrients. It transports oxygen and hormones to cells throughout the body, and removal of waste product, that's carbon dioxide and nitrogenous waste. You can now know, as we begin to lay some solid foundation to our workshop today, that blood plays a very critical role in the life of an individual, the life of human being, living human being. And that's why you see, once it is compromised, transportation is also compromised. There will not be well vascularization of the targeted area. We will explore into that very soon. And the nutrients that's supposed to get to the different area will not get there. And that's why you see those structures will not get, will look malnourished and will not be able to further perform what they are supposed to be performing, and sort of the conditioning begin to set in. And also there will be accumulation of waste product around. The second function is protection. It's also a protector. And by doing this, there is circulation of the white blood cells, the antibodies, the complement protein that defend the body against toxins and microbes. You can also deduce from this now that once it is compromised, the immune system also will most likely be compromised. The third on the tripod, we'll talk about regulation, we'll talk about transportation, we'll talk about protection. We are talking about regulation now. Is body temperature, the fluid pH, and the water content within the cells in order to maintain the homeostasis of the body, which of course is a self-regulatory system of any human being, and which also leads to a lot of well-being of human being once it is well maintained, the homeostasis is maintained. But in the instance whereby the cardiovascular system is compromised, it is also expected that regulation function will also be compromised, and the homeostasis will not be as supposed to be. The heart, when you make a fist, the heart is like a fist-sized organ. Fist-sized organ. Just try and make a fist for the slide 12 that is in front of you, put the heart that you see there. So it's a fixed size organ which is vital for life. You've not seen any woman being that his heart is taken away and it's still working. No, it's not possible. So, but there's slight difference in size from individual to individual. The average adult size is about 10 pounds, but it may weigh little or more depending on the body size, depending on the sex, and also depending on the condition of the individual. Now, you also see that in almost also they go for chest X-ray, The chest X-ray that is gotten is not essentially to look at the sex, the lung alone. There are a lot of things that need to be understood in this in taking of the chest X-ray. And typical for this particular workshop that we're having now, this is why this is there. You see that in this particular AP view of this of this particular individual, the chest X-ray, there are some things I want you to really take note of there as I move my cursor. There is the right heart border, that is the red color there. Then there is the left heart border, that is almost like milkish yellow color there. There's right hemi-diaphragm, which is at the lower end of the right long field. Then there is the left hemi-diaphragm, which is at the end of the left long field. Of course, you see that there is a space here, and that is what is taken to be cardiothoracic ratio. Now, that is when this other slide, that where my cursor is here now, the diameter of the widest point of the heart to the widest point of the chest, when you put this upon this, whatever that is gotten supposed to be between 0.42 to 0.5. That is what is called cardiothoracic ratio. It is a measurement of the chest that is taken through the X-ray, and it is relative to the heart, it's relative to the chest. Like I said, this arrow cursor number 1, with the diameter that is gotten over the diameter of these two will give you between 0.42 to 0.5. Now, when this, we call it CTR, cardiothoracic ratio. When this cardiothoracic ratio is greater than this particular 0.5 or 50%, as it may say in some instances, it indicates cardiomegaly. That is the enlargement of the heart. Now, we'll see there are some, we need to also explore for the children. There's, we have some of us into pediatric practice that will benefit from the, still talking about cardiothoracic ratio. You see the X-ray of the children, their own is a bit different. For the newborn, up to 60% is considered as normal. Between 2 to 4 years, 50 to 60%. And for children that are greater than 4 years, maybe up to 50%. So this is how the CTR that you hear about, cardiothoracic ratio, is gotten. It is, once again, let me explain to you, the widest diameter of the heart over the widest diameter of the chest. That is it. But there are factors that affect it. Of course, one is age, as you have seen from the illustration I gave for the pediatrics there, higher figure, but as they grow up, they begin to normalize to like an adult. Then the body posture too can also affect this ratio. The CTR can be affected by patient's posture during X-ray, like in supine or standing. Also, some technical factors can affect it. Technical factors like quality of the X-ray. Respiration too can affect it, like whether the patient is taking deep breathing or not, the chest is drawn in or not, it can affect it. And also underlying conditions like peritoneal lung disease can affect the cardiothoracic ratio. I know with this, you'll be able to begin to figure out easily what is interpreted or what is written in X-ray report as cardiomegaly, of course, which is one of the things that is seen when there's a patient is having prolonged hypertension. Now, heart beats 100,000 times per day, pumping about 8 pints of blood. It pumps about 8 pints of blood, and it beats 100 times per day. And you can now see that it's a big work that it's doing throughout the lifetime of an individual. It contracts, it empties the blood. When it relaxes, it fills the ball. You can see contraction, bring your hand together as a way of illustration. When you are bringing your hand together, you see that the space is reduced of your hand. It's like your hand is about to touch each other. So the blood is emptied, it's removed, it's pumped out. So when it relaxes, the blood now flowing, and that's of course about 60 to 80 times per minute. Then it is located in front of the chest, is slightly behind and to the left of the sternum breastbone and middle of the chest. I may put on my video in the course of presentation and show you some of these things. I bring my stethoscope and begin to see, because there are some landmarks there. Even though in this presentation too, I've been able to isolate it out, the landmark that you know where to put your stethoscope to be able to get each particular sound at each particular time. But you must be able to still remember your anatomy very well and be able to pick each of the slammer. When you pick this slammer, you'll be able to pick your stethoscope and go there. Then it's slightly to the left side of the body. And that's why you see that the structure of the lung, of the left lung, is different from that of the right lung. The right lung is upper middle basal lobes. For the left, it's just apical and basal and maybe lingular separated. And that's why you see now there's an oval indentation, like a convex or concave, whichever direction you want to look at it. That's where the heart is seated. And that's now what makes the left lung to be smaller in order to make room for the heart. Of course, the heart is protected by the rib cage. Let me delve into the issue of the pulse, how you can take pulse of a patient, which is part of the assessment. Now, there are different points that pulse can be taken, even though it's the radial pulse that is for commonest that is done. But it can be taken at the temporal bone. You can put your hand close to the temporomandibular joint area. You see there that there's a pulse that can be taken there. Also, it can be taken at the carotid artery by the side of the neck. That's where my cursor is now. Let me try. Yes, that's why my cursor is. It can be taken there. Also, this is for the brachial artery, just by the entrance to the elbow. Yeah. Then there is that of the radial artery, which of course is the common one that we do. Then a dorsal pelvis artery, that is by the foot of the individual. You locate it there and you put your finger there, then the pulse can be taken there. There's also the femoral artery, which is done by the inguinal region. You can palpate it as we are going through this lecture, through this workshop, and begin to see what I'm talking about. This provides options in taking the pulse for the patient. And for instances whereby you cannot locate it by the radial, you can fall onto any of these 7 other options that is given. And for the popliteal artery, you go to the back of the knee and use your index finger and the middle finger to be able to do the palpation and to be able to get the pulse. And finally, there is the posterior tibial artery too, which is judged by the medial aspect of the ankle, just about it, and then the pulse can also be taken from that angle. So you can see now from the image that is given here now, the landmark is clear there. Their temporal region, carotid region, the brachial one, the radial one, the popliteal one, the posterior tibial artery, and then the femoral artery. These are different points in which can be taken. This, I expect that as we are talking, going through this lecture, you'll be able to locate that one by yourself and be able to see. So about 2-3 illustrations is given here for you for continuous reference and for you to continually practice it, so that at any point in time, you can pick the pulse of a patient from any particular point. And even if it is not possible from the conventional radial one, you fall into the other one and be able to pick it. Then there's alien test. I also want to teach us, which is very important to us, which talks about importance of it is in vascularization of the hand. I want to know the kind of venous return of blood into the hand at a particular point. There are 2 modes of it. I will discuss it with us, and I will also try to contrast the difference between 2 of them. They are not too much different, but you also need to know the difference between them. It's a very simple procedure, as the diagram has shown. Well, very, very important prior to radial artery cannulation, or we want to do anterior plug gas sampling, which of course, is some of the results that we fall back on before we make some of our decision, or we also monitor the progress of the patient. So we should know about the alien test. The alien actually is not the name of a person per se. It's an acronym that I will decode onto us. It's like ALLEN. But don't forget, it talks more about how blood returns back to the hand or not. And it has to do with pressure on the radial and the ulnar artery. Now, the first A there, like I told you, is not the name of the person, it's an acronym. The first A there means pressure on the radial and the ulnar artery. And you can see this man. if you can see this man here now, is the pressure there with the index finger and the middle finger. There's a pressure on the radial artery there, outside there, and the medial artery here now. So there's pressure that is applied to them. That's the first A. The second L here is the patient is now made to open the hand and close it, like clenches, open and close, open and close, open and close. Then the second L there is losing the pressure on the ulnar artery. That's the one on the medial aspect now. The artery that you palpate on the medial aspect now, the pressure there is losing. That's the second L. The E now is that you don't evaluate the return of the blood onto the hand. There will be blanch. I will show you a picture very soon. It will be like for people that are light in complexion, you will easily see that it's like the hand has almost turned blue because you have occluded blood flow to that area. Then when in that evaluation now, you want to know the time it's going to take to return back to normal. And that brings us to N there, the last N there in the Allen, the normal response. And this is graded this way. And grade 0 is no return of color. That means it is actually compromised. Then grade 1 is color return after greater than 10 seconds. Grade 2 is sluggish, and then the return between 5 to 10 seconds. And grade 3, there's big return in less than 5 seconds. This is actually the ghost reference. Okay, so I'm sorry. This is actually the gold reference, the issue of less than 5 seconds. It shows that there is an easy return, venous return onto the hand. Don't forget again, it has to do with grade 0, grade 1, grade 2, grade 3. And it has to do with vascularization of the hand, most especially in the procedures like radial artery cannulation, arterial blood gases. Some of the report that you see in the file of patient, or the patient tell you they went for a test like that. This is what is needed to be done, and it's a procedure, it's a test that we should be able to carry out on our own. Now there's a modified form of it. The conventional of it is for the two fingers to be there to palpate the radial and the ulnar artery at the same time. Now but the other form of it is just going to be for only one hand at a time. And that is why they say modify Allen test. So it's not so different. The only difference is just that one is done simultaneously for the two hands, whereas the other one is done singly for each of the hands. This is the blanch that I told us will happen. Can you see now that there's a reduced flow here now? So the time it will take for this to come back to normal is graded, is what we're going to determine whether it's grade 0, grade 1, grade 2, or grade 3. Now, still talking about the Allen test. This talking about the Allen test. Now, I told us that we will see something called MAT. MAT has to do with modified Allen test. They are both used to assess blood flow to the hand, like I told us. Now, the original one, it is simultaneous assessment. Now, for the modified one, individual hand is assessed. So that is the difference. Don't think that it's completely different from one another. No, the issue is that one is simultaneously done, the other one is one hand at a time. And on this side of this particular slide, I've tried to show you the difference between the two of them. Now, simultaneous or individual, for the original is done simultaneously for both hands. For modified, it is done for one hand at a time. Artery assessment done for both radial and ulnar artery simultaneously for original hernia. For modified hernia, assessment is either for. So those are the differences that we have with it. I'm sure I'll give you 2 minutes now to practice on your own. On the radial artery, on the Fine. Pulse oximetry, you should not have much challenge about that, but I would suggest that you check the battery of your pulse oximeter from time to time so that the reading you are taking, you can be very sure of it and you can be able to reference it. Of course, you need to monitor that during exercise program so that you know how the patient is responding. If the pulse oximetry is going down, if the percentage is going down, you definitely know that the patient will not be able to cope very well. And if it's going further down, you may need to terminate the procedure for that day and wait for another time or wait for some minutes before you are going to continue managing that patient. Then this has to do with pulmonary embolism. Let me pause here and quickly say this. Anytime you see PE is non-physical education. PE in this instance, when it comes to heart and cardiovascular assessment, is pulmonary embolism. Once you see it as part of the referral, it's a guidance to you what is happening, and you may need to further probe into the history of the patient, whether that is there or not. Then pulmonary embolism is had to do with the blockage in one of the pulmonary arteries to the lung. And you can know what this actually means, that they could be caused by a blood clot that travel to the lung from the leg. Maybe it's undetected and you now go to that place and you know in that instant you could be so fatal. That's why when there is case of DVT, that's why it's relevant to our presentation, our workshop today. Its caution is usually taken and the patient is placed on anticoagulant and then we'll monitor until it's free. And that's to introduce us to the next slide here, the deep vein thrombosis. Of course, I'm going to compare this with another condition so that you don't mix up any of the two anytime you see. So deep vein thrombosis is a possibility here now. It's a clot that happens in a deep vein, and the signs and symptoms are what they call cow. Cow is C there is calf pain and cramping. O there is one-sided swelling, which is unilateral, as you can see in this instance. W there is warm and red. When you touch it, gently touch it, not touching or squeezing, then you see that it's actually warm and it's red in color. If you see the illustration that is given here now, this color is a bit different. The S there is soap and chest pain. Where once there is issue of chest pain there, you may probably begin to suspect the PE I told us about, pulmonary embolism. And the treatment here that associated to us at that particular point in time is a refrain from management for some time for the further the results until the result comes out that this patient is cleared of this and the protocol can continue. Then the second thing is a venous return elevate. Then the chart there is that after the clot, we'll begin to do our ab stuff. That is the ankle pump exercises. Very important, our isometric stuff, because that will help to drain. And that's why even when people, and have told us in the next few minutes, you have make us to stand. When somebody is in prolonged position for a long period of time, we recommend ankle pump exercises for that particular regimen. As simple as it is going to go a long way in saving the life of that individual, and also for a patient that has suffered this before and has been cleared of it. We look at this chart, it is the ankle pump exercises, the isometrics will work. The H there is hydration, and then the A there is ambulation. We don't want the patient to be in the same place. In fact, that underscore the importance of our protocol. That's underscore the importance of physiotherapy. And that's why I'm convinced that throughout ages, throughout, physiotherapy will continue to be relevant in the management of patients. Because we can't keep a particular individual in a place. An individual has been so much customized, permit me to use that word, in terms of his biomechanics, to move. So not moving, he has his own implication. So one of the first protocol, if it is not completely contraindicated, that has to be looked at in the management of a patient is ambulation. And I want to convincingly tell you, this is one thing I've leveraged on in my clinical practice. I try to get my patient on the feet as fast as possible once there is no complete contraindication, so as to mitigate all these effects that we are discussing today. Of course, there is no sitting long. There's the car issue of car, airplane, bed rest. Of course, when the person have to travel in car for a long period of time, the necessary advice need to be given to the person. And if it has to be plane, in a plane, that's why you see some instances they say the person is not clear to fly. It's not clear to travel by flight because there is a possibility of the death. Of course, the tech sucks there. Of course, you see our patient who need it, we need to stock our department with that. And then if we don't have a department, we may need to give some advice onto our patient on what they need to buy the tech sock, which this is after the clot has already been resolved. Now, I need to teach this so that you don't mix up the two in case you see it. This leg that you are seeing that the cushion is on is cellulitis. Is cellulitis. Anytime you see a color like this, is cellulitis. It's different from deep vein thrombosis. And these are the difference between the two of them now. For cellulitis, start to do with bacterial infection. Bacterial infection, that is all what's all about, of the skin, of the subcutaneous tissue. But for deep vein, like I previously said, it has to do with blood clots in the deep vein of the lower limb. Please note that. In fact, you from this picture I've given unto you now, I expect on your feet, you'll be able to say, oh, this is not DVT, this is cellulitis, and appropriate thing will be done. And of course, you also know that management differs in the two cases. Antibiotics is the order of management in the cellulitis, but different thrombosis has to do with the anticoagulant. Of course, the tests that need to be done, I will go into it in the next few slides for you to be able to identify what DVT is all about, and now once you are suspecting it. Now, of course, when you talk about pitting edema, it's less common in cellulitis. It's less common in cellulitis, but it's common in DVT. Then, when you look at the issue of pain, there's constant pain in the affected area in cellulitis, but for the DVT, pain is often worse with calf compression and ankle dorsiflexion. But even though you have to be very careful with Oman sign, once you notice I suspected that DVT may not need to go into this particular sign. The cellulitis is ultrasound DVT. The diagnostic test is a venous Doppler ultrasound, which is gold standard of diagnosis. I want to create for indulgence. At times, you may need to visit the department of radiology to see this procedure as it's done, so that when it comes to you, you'll be able to also understand how it relates to your patient when you need to refrain or not. Like I said, treatment for the cellulitis is antibiotics. For the deep vein is anticoagulant therapy, offering in different doses, 2.5 milligrams. Now look at this picture, because we are revisiting our anatomy to be able to establish some basis now, so that in examining our patient, we'll be able to know what to do, where we put our stethoscope and put. The importance of this beyond the vessels that have been highlighted. First of all, we look at the interstitial triangle here. Then we look at my particular interest here is the position of the clavicle. Once you get the clavicle, the first rib starts almost beneath the clavicle. And it's from there now you begin to now count the intercostal space one after the other. This intercostal space is beyond anatomy. It is going to the realm of clinical anatomy because it's of significance even unto us in the management of the. Don't forget, the first rib winds under the clavicle, and that's why you see when there's clavicular fracture, depending on the area that it affects, if it affects this particular area now, not towards the coracoid process, you expect that its tendency, of course, if it's also displayed, that it may affect the first rib, and the lung, the apical lobe, may be affected in the process. Now, this brings me to the heart sound. That is the reason why I talk about, but I want you to stand up and stretch yourself for the next 2 minutes before I go on. We have gone for long, for almost 50 minutes. Please stand up, stretch your leg. We'll continue very soon. 2 minutes I give us. Stretch your leg. Stretch your leg, please. We'll begin to move very soon. Stretch your leg. Thank you. You are welcome back. I believe you have stretched your leg now. Let's go on. You are welcome back. Let's pick from where we stopped the other time. We've been able to locate the place where the rib starts from. We'll be able to locate that is beneath the clavicle. We've also know what can make it to be susceptible to in case of an injury. But this is actually very important for us as we begin to pick some landmark. I want you to see in the taking of the heart sound. Now, there's this acronym of EPET-M. Now, the A there is has to do with aortic sound, and that has to do with the second intercostal space. As you can see there now, I will go from one arrow to the other. It has to do with the second intercostal space on the right. On the right. Second intercostal space on the right, that's where you are going to get the aortic area there now. That is to the right of the sternum is the second intercostal space. Now, beside it, that is pulmonic area. That is also the second intercostal space, but by the left of the sternum. Second intercostal space by the left of the sternum. Then just beneath it, the third intercostal space, that is the F point, which is also the left of the sternum, but the third intercostal space. Beneath that is the tricuspid area, which is now the fourth. Don't forget where we started this tracing from. We started from immediately under the clavicle. We got the first intercostal space. From there, we veer off to the right side of the sternum. We got the aortic area. We veer off to the left side of the sternum, we got the pulmonic area. Then beneath it is the S point, which is the third intercostal space. And then beneath that third intercostal space, the fourth intercostal space, which has to do with tricuspid. I'm still going to break down this anatomy of the heart very soon. But I want you to locate all these particular points as I'm teaching us. So it's like 5 points you must know. The first intercostal space, the second intercostal space, the left of it, the right of it, the third intercostal space, the fourth intercostal space, and the fifth intercostal space. The fifth intercostal space has to do the far left, and that has to do with the mitral area, is the far left of the sternum. So these 5 things now, anywhere I meet you, I should be able to ask you, even before we end up this particular workshop today, for you to give me the answer to this. For you to give me the answer to this. So the first intercostal, the second intercostal, the left of it, the right of it, the third intercostal, beneath it, that's the S point, the tricuspid area, which is the fourth intercostal space, still the left of the sternum, and the mitral area, which is far left, which has to do with the fifth intercostal space. I believe this now, you'll be able to pick it there. Very, very important for us to move on. So we move on now to the next thing, please. Give me some time. Okay, fine. And that's what you now see here now, that is being demonstrated practically. Now, all those explanations I've given unto you now is what is being demonstrated now. You see this stethoscope now is put here now by this demonstrator on the second intercostal space, the right side of it. That's the demonstration of it now. Now, that is the aortic area. Now, he has moved now to the left aspect of it, which is the pulmonary valve area. And that is still the second intercostal space, but the left side of it, the left side of sternum. Don't forget, sternum is here. We will be able to trace through now. Now, okay, that's the pulmonary now. This has stated it very well. Sorry, network problem. Are you hearing me? Are you hearing me?
Yes, sir.
Are you hearing me?
We can hear you, sir.
Now,
yes,
okay, fine. Thank
yes,
you. Now, okay, now I will now trace down. You know, that is the second intercostal space where you have the pulmonary valve there. Now, you now trace down immediately down there. That's the third one. That is the S point. And that's where you see we are putting, and that's where he has put this stethoscope now. It's now marked in this space. Now, after that, now, you go to the fourth intercostal space. That is the tricuspid. That is beneath the S point. That's the fourth one. Second, third, fourth. That's the tricuspid now. Immediately that is done now, you veer to the left. Look at my cursor. Sorry, let me get my cursor. Okay, let me get my cursor. Immediately you get the tricuspid, you veer to the left of it, down, a bit down it. That is the fifth intercostal space. You now get the mitral valve area. So that is what it takes. Now, I'll be able to pick that for you now. Anywhere I meet you, you should be a master of that. You should be able to demonstrate that. You should be able to pick those sounds from the patient. Now, let's further go into dissecting the heart. The heart contains 5 muscular sections, chambers. He has his own chambers through which he operates with as vital as it is. Now, he controls these chambers control the rhythm and the speed of the heart rate. We're going to talk about something of heart rate. There's a lot of variants, a lot of things that we need to actually pick up from the structure of the heart and some tests and all like that, which I will talk about later on. Now, it maintains the blood pressure. These chambers maintain the blood pressure. It also moves the blood throughout the body in a coordinated fashion. It's very interesting. It's very interesting that an organ that is fist-sized, like I said when I started this lecture, can be so coordinated in moving things around this chamber. And the way it has been so much fashioned is anatomically beautiful, anatomically admirable, really. So we move on. So we send oxygen out and remove waste product. Now, also electrical impulses that makes the heart to beat. It has its own electrical chamber, electrical area that makes work very well. We are going to explore that one too in the course. Now, the nervous system, they directly function and that they direct the heart function. And many conditions, this is not working very well. Now, let's look at the synergistic work of the heart. The heart works with other body systems. It doesn't work in isolation. They work together. And that's why I say in cardiopulmonary, you tend to come to know that you are playing a vital role in the life of a particular individual and also in the life of a patient. It works together with the other body system. Suffice it to say, in the presentation today, we are going to liken it and link it to the brain. And I cause we see some of these conditions that is cardiovascular defect of the patient. Now, the nervous system controls the heart rate. Signals to the heart to beat. As simple as that procedure is, your patient comes, sit down, take the blood pressure, and take the heart rate. It's not a small process at all. It's a process that is going to determine a lot of things, that is going to give you a lot of variance, that is going to give you the picture of that particular patient. I'm going to tell you more later on at the course of this study. So also the endocrine system too, it sends out the hormone, and also in the process of relaxing and contracting. Now, we take blood pressure. We take blood pressure, there's upper one, there's lower one. There's one over another one. So each heartbeat has two parts, the diastole and the systole. The systole is when the ventricle contracts. Don't forget, when we started this presentation, I asked you to bring your two hands as if you want to bring it together. Once you are trying to bring your hand together, you see the space is reduced. That is contraction. And when the space is reduced, imagine that it is blood that is filled the space between your hand. What will happen to the blood is pushed out. So that is systole there. Now, and then after that one, we have the diastole. That's the second figure that you have down. So the diastole has to do with the ventricle relaxing and filling the blood. But all these things we are talking about happen within seconds, happen within moment. Because heart doesn't stop. The moment it stops, you know what it means. So as it contracts, it relax, it contracts, relax. That's what gives you your boom, 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 boom. And that's the kind of sound you are going to get in the process of of your auscultation, in the process of listening to heart sound there. So now let's do a bit of contrast relating to the ECG now. Now, for systole, the timing is after the heart's electrical impulse leading to the QRS part of the, there's this P in an ECG. So I'm trying to link it with it now so that you understand that it's not just a figure that we are picking. The figure has its own clinical implication. Now, the diastole, the timing is after the systole. It is not by relaxation, and that's the part you see the T wave there now. So what do I want you to pick from this? Pick this, that systole function delivers oxygenated blood to the body and the oxygenated blood to the lungs. For diastole, the heart will fill to ensure adequate blood supply to the next contraction. And that's what keeps up on here and there, and you can keep on checking the blood pressure. Now, the issue of blood pressure is not to be taken anyhow. This is from the American College of Cardiology. American College of Cardiology. Now look at things that can change the figure that you are picking that may not make it accurate. Talking may increase the blood pressure between 4 to 19 millimeter mercury. So for some that you are taking, your patient come, you have done the right thing, you want to check the blood pressure, but the patient is still busy talking to his friend that has also come for consultation. He's going to introduce variants. He's going to introduce variants to what you are taking. Then some too will say that let me just wipe the cough around the shirt. Maybe you come with long shirt. In fact, we may need to, if the patient is the type that don't want to be undressing, maybe when you are coming for a consultation, maybe you wear a dress that you can easily fold the arm of this. You can give that counsel to the patient. So if you put the cough on the shirt, it may increase the BP between 3 to 5 millimeter mercury. Then also using a cuff size too small may overestimate the BP between 5 to 20 millimeter mercury. Then when the arm is hanging freely, it may increase BP by 5 to 20 millimeter mercury. I want you, when you get this slide of this presentation, I want you to pick this and put it in your clinic. Put it in your patient, where you see patient. It may even be your office to keep remembering you. And you may even point the attention before you start your patient on a day. You just about 2-3 minutes talk with your patient. Please, I have this thing that I've put in our patient on the wall. I want you to read it anytime you come here. So I want to be taking good measurement, accurate blood pressure for you. But there are some things you need to do to cooperate with me for me to take adequate blood pressure for you. And then you point the attention. Also, the crossing of leg. The crossing of leg may increase the blood pressure by 3 to 15 millimeter mercury. So from today, I want us to be careful in the way we measure the blood. Very lastly, let me say this before I flip over. A full bladder, this will interest you. A full bladder may increase blood pressure by 4 to 33 millimeter mercury. Now, this is significant. Beyond the taking of the blood pressure alone, you flip your mind to some procedure that you have to still do for the patient. And then that this has now already increased it, and then you want to do that particular procedure, you know what it means. I also want to introduce us to MAP. MAP is mean arterial pressure. I want you to please take good note of this. You will need it. You will need it in cardiovascular assessment. You will need it in management of patient in critical condition, what we call critical care. It's very important. Of course, I will tell you how it's computed, but I will also show to you where you can easily get it without doing the computation on your own. But I deliberately brought some figure here that we can fiddle with so that you now know how it comes out, but I will show you where you can easily pick it up. But it's very, very relevant, MAP. In fact, the slide after this slide, you see my handwriting, written, scribble some things down for you to be able to go through there now, for you to know that MAP is very important. MAP is mean arterial pressure. What does it mean? It is actually the pressure throughout one cardiac cycle, the systole and the diastole that I have talked about earlier on. It's an indicator of blood flow and is believed to be a better indicator of tissue perfusion. You now know what it's all about now. Tissue perfusion, and it's a very critical thing. I've seen this play out in the life. If the one thing I like checking when I'm in ICU, when I'm in a high density unit, HDU, is something I like checking. It gives me, it makes me to almost procrastinate concerning a patient. Oh, this patient is doing fine. This patient is going to pull out of it. And I've actually seen some wonderful things happening through this figure of MAP. So it has to do with perfusion of vital organ. Now, how it is done. Flip to the right side of this screen now. Let me bring my cursor there now. You see the common formula that is used. About 3 formula that is used. A mean arterial pressure is diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. Oh, you say you have a big formula before you. Yes, I just want you to see this. I just want you to see how it plays out, but I will tell you where you can easily pick the figure from. Now, it can also, it's about 3 formula there now. It can also be the diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. Or it can be diastolic blood pressure plus 1/3 of pulse pressure, or systolic blood pressure plus 2 times diastolic blood pressure divided by 3. Now, we pick a figure, imaginary figure of a patient. Let's say a patient's blood pressure is 82 systolic versus diastolic of 50 millimeter mercury. The MAP of that patient, if you are going to follow the formula of this last one we give, the systolic blood pressure there is 82. The diastolic blood pressure is 50. So 2 times 82 plus 2 times 50, that will give you 100 plus 82. That's 182, isn't it? You divide it by 3, you get what? 60.67 millimeter mercury. That is God. But you can also, for you to know that all this formula will get the same figure for you now. Let's go and pick the one of 1/3 of systolic blood pressure minus diastolic blood pressure plus diastolic blood pressure. If you use that same formula too, even though you go do some computation a bit different from the beginning, but it's going to result into the same figure too, because look at this, 1/3 is out, but systolic minus diastolic is 82 minus 50. That is 32, isn't it? Then plus the diastolic is 50. Now, okay, sorry, we have not. We said this one is what? Is 32. 32 divided by 3. You know, it has to be divided by 3. Divided by 3 there will give you 10.67. You now go and add it to the diastolic plus diastolic 50. You still get 60.67 millimeter mercury. So that is how it's gotten. Now, take note of this now. To perfuse vital organs, it requires maintenance of a minimum of mean arterial pressure of 60 millimeter mercury. Now, there is no glory in it increasing. So maybe let it increase. So, 60 can do what? If you make it greater than can also no. To increase excessively, it has danger. To reduce excessively, it has danger. And that's the note I said I'm going to introduce you into it. I want you to as a take home there now. So like I said, organs, it draws below this point for what we call end organ manifestation. That can occur. Now, if the MAP draws significantly, blood will not be able to perfuse cerebral tissues, brain, and you know what that's actually going to translate into. So it is intention of MAP. What MAP does, it functions to perfuse blood to the tissues of the body. So it must not be too low. I told you it should not be sufficiently perfused. Now, if it is elevated too, if the elevated contribute to increase work of the heart, and that can also cause damage to the heart. You cannot see how it's related to our presentation, how it's related to cardiopulmonary hepatitis, how it's related to cardiovascular assessment. So I leave you again with MAP, you should know it. Minimum required for sufficient perfusion is what? Somebody to answer is what? What is the minimum value of MAP for vital organ maintenance?
60 millimeter mercury.
It's okay. Thank you. Now, if it is too high, what does it mean? What will happen?
Organ damage.
Okay, thank you. Organ damage, if it's too low, if it's too high, the heart will be working too much. I've taught you on how to compute, and I know you can compute if you throw imaginary figure for yourself, or even if you have a patient with you, you've taken the blood pressure, you can compute from any of those 3-4 formulas. But good news, you don't need to compute when you're in ICU, when you're EDU. Just look at the monitor. You will see there, watch towards, I think, by the left side of the monitor, you see MAP. MAP, are you getting me? Don't forget, look at the monitor in ICU or AGU, or even if you are in sophisticated center that they still have that in their center, their patient, look at the left side of that monitor, you will see what they call MAP. So you don't need formula, you don't need paper to begin to compute. I just deliberately expose you to that formula so that when you are in a system that doesn't have that, you can easily compute by yourself. So we go on. The functions of the heart. Now, the coordinated actions of the chambers. I told you heart has chambers, which I'm still going to dissect very soon, of the valve, of the blood vessel, contribute to maintaining the circulation. And let's look at the primary function here now. Let me dissect that. We have the pumping of blood, we have the circulation, we have the oxygen transport, we have the nutrient delivery, waste removal, maintaining blood pressure, electrical conduction, and vital organ support. And then let's look at the anatomy now of the heart. It is structured deliberately to be able to perform the work for which it's meant for. It has the walls, just like the wall of the house. It has the chambers. I want you to look at this illustration very well. Look at the wall of your house. After the wall of your house, once you enter the house, where do you go to? You go to the room. From the room, you do what? You go to the close, like the doors, and that has to be the valve. I will show you the valve very soon. I will show you how heart works. It's so explicit that any point in time you just want to play with it, you just want to be able to explain it out. That this is how vital this is. You look at the wall, you look at the chamber, you look at the valves, then you look at the blood vessels, which is like the pipes in your house that carry the water. And then you look at the electrical conduction system, which is the electrical power behind the building. Once the electrical system of a house is not there, there will not be light. So the same thing with the house. So don't forget this illustration. The wall, of course, we'll look at the wall very soon. We'll dissect it to the chamber, to the valve, to the blood vessel, to the electrical conduction system. Now, let's look at the wall. Now, contracting and relaxing the muscles send the blood throughout the body. Now, there's a layer of muscular tissue, which is called septum. It divides the heart into right and left. Heart has right, it has left. Don't forget those first intercostal space, second intercostal, left, right, third, fourth, fifth. Now, I've been able to distinguish between left and right. The second intercostal space, the right side of it, is what? Is left, where we said is the aortic area of it now. So it is separated by the septum, and it has 3 layers. The 3 layers are this. The wall of the heart has 3 layers. We have the endocardium, which is the endo. Cardio, anything cardio has to do with the heart. Now, endo is the inner layer. Myo is the middle layer. So you can develop your mnemonics to be able to remember. Once you see M, means middle. Of course, endo is inside. Endo is the inner layer. Myocardium is middle, the middle layer. Then epicardium, epi, the one that is, you remember your epidermis, the one that is the coat, the one that is covering it. So epicardium is one layer of pericardium. Pericardium is a protective sac of the heart that covers the entire heart, and it produces fluid that lubricates the heart and keep it from rubbing against the other organ. So it's like, you know, it's like when you put oil between two structures, you see how it flows together. But when there is no oil, there will be friction. But in this instance, the fluid is there that lubricates it, that makes the movement very easy. And this is the pictorial for it now, for us to see now. This is the endocardium, where my cursor is the inner layer, the middle layer, the the myocardium, and then the outer layer, the pericardium. Of course, this is the fluid that we talk about that allow easy movement of it, no friction at all. Now, there's what is called cardiac action potential, initiated by what we call the pacemakers of the heart, and it's as a result of the contraction of the heart by the muscles of the heart. I want to take note of this, and it's actually about the same process that happens in muscle, the process of polarization and repolarization, essentially controlled by the pacemakers. Now, the cardiac action is initiated by these pacemakers. Take note of this. They are located in the SA node. I would say that one too very soon now. The sinoarterial node, they are located there now. It has different phases, about 4 phases. There's depolarization there, where there's rapid influx of sodium ion into the cells. Then after that has happened, it goes into the early repolarization. You know, the polarization is the depolarization. Depolarization is rapid influx. Gate is open. The sodium ion goes in. Then after that goes into the phase 1, which is early repolarization. In this instance now, potassium channels open and sodium channels is closed, is inactivated. Now, then the phase 2 now is plateau phase, which has to do with the influx of the calcium ion. Please take note of this. We are dealing with the sodium ion, potassium ion, calcium ion. Those are the 3 things there. Sodium ion, potassium ion, calcium ion. The first process, influx of sodium ion. The second process, potassium channels are open, sodium channels are inactivated. The third process there, which is phase 2, which is the plateau phase, there's influx of calcium ion. Then we now go to phase 3, which is repolarization. In phase 3, potassium ions channels open, allowing the potassium ions to flow out of the cell. And finally, phase 4 is the resting potential, where the cell returns back to its resting place before it begins to move on. So these are the processes that takes place here and there all the time. And the duration of the cardiac action actually is longer than in nerve or skeletal muscle. I want you to take note of that. You know, I've likened it to the skeletal muscle contraction. Vis-a-vis the nerve, of course, which is what we play with in the issue of stimulation per se. Now, but this is a process that is faster. The duration here is faster. Of course, it has to be faster. That should be well understood. That should be easily understood, because we are talking about art. I told us the rhythmicity of his action there now is so faster than the issue of skeletal muscle. And then there are 2 types of cardiac action potential. There's the rapid one and the fast one, or you may call it rapid, and the slow one. The fast response action potential has to do with rapid upstroke due to sodium influx. Then the slow response to action potential has to do with slow repolarization phase due to calcium influx. So in case I give you quiz, in case I ask you question, fast one, is it potassium? Is it calcium? What are you going to tell me? Answer, please. Fast response to action potential, it has to do with which influx? Ion influx. Hello, let me hear you very well. It has to do with which ion influx?
Sodium.
Okay, thank you very much. That's a good one.
Sodium influx.
It's okay. Thank you very much. Thank you very much. So I'll give you 2 minutes to stretch your leg now. It's another 30 minutes. Stretch your leg. Then we'll continue after 2 minutes. From which center? Why? Where? Yeah. What's your name? What's your name? How come I've not met you before? Where do you work? Where did you finish from? Which year? You have not met me before. That's weird. Sorry, weekend, that is always fun. They were messaging me, but I have to any lecture I deliver, I used to give them break every 30 minutes so that they can speak. You're welcome. Hope you are getting it. One minute more, then we'll reconvene the class. Now let's come back to class. Let's come back to class. You have stretched your leg, and I hope you did stretch your leg. Let's come back to class. Okay, let's come back to class. Okay, let me go back. Okay, now let's look at the chambers now. We've talked about the wall. We've talked about the action potential. We've talked about the relevance of the calcium ion, the potassium ion, and the sodium ion. We talked about the fast action potential, the slow action potential. Now we'll go to the heart chambers now. Like I told you, the heart is divided into two halves, left and right, separated by septum. Then the two halves is further divided now into four chambers, two on top, two bottom. Now, two on top is actually atrium, singular, atria. That's why you have the right atrium, the left atrium, and the two atria. Then bottom is ventricle. So don't forget this picture again. When you put your hand like this under each other, the one on top has to do with the atrium. The one down has to do with what? Ventricle. And that you now make it to have right atrium, left atrium, right ventricle, left ventricle. I'm sure we've gotten that now. Then there's, for the right atrium, there are two large veins that deliver the oxygenated blood to the right atrium. That's the superior vena cava, which carries blood from the upper body. You will see it. It carries, boom, it drop it. By the time the process wants to start, it carried all the blood from the upper body, maybe from the head side, and drop it in the atrium. Now, inferior vena cava carried it from the under. I will show you the picture of all this to illustrate it. But don't forget, these two vena cava vessels, they are very important. These veins are very important. The superior one carries the oxygenated blood from the upper part of the body. The inferior one carries the oxygenated blood from the lower part of the body. They bring it to the atrium, so that the atrium now will be able to now take the blood to the right ventricle. That introduces us to the right ventricle. Now, the right ventricle is the lower right chamber. Don't forget, I told you atrium is on top, ventricle is down. Now, the lower right chamber is the lower right chamber. Then it pumps the oxygenated blood to the lung via the pulmonary artery. And this is the difference now. You know that it's vein that actually carries the oxygenated blood and actually carry oxygenated blood, but the reverse is in the pulmonary vessels. We'll take note of that now. So the pulmonary actually carry the deoxygenated blood. Atrium, right atrium, and the right ventricle, they work side by side. Right atrium, after it has been fed by the inferior and the superior vena cava, getting things from the upper body and the lower body, it empties into the what? Into the right ventricle. The same as the oxygenated blood. And that same oxygenated blood now is now taken by the pulmonary artery to the lung. That's the next thing there, because they want to remove everything there and oxygenate it. That is the process there. So the blood reloads the blood with oxygen, making it oxygenated blood. Now, after it has been oxygenated in the lung, don't forget the parts. Right atrium, right ventricle. Right ventricle, it goes through the pulmonary artery to the lung. With the lung, it gets its oxygenated. It's now brought back by a pulmonary vein. That looks strange, isn't it? Vein carrying oxygenated blood, isn't it? It's against the norms. That is the only difference now when you understand your cardiovascular system very well. That when it gets to the heart, vein carry oxygenated, artery carry deoxygenated, but in the other part of the body is the other way around now. So after it has been oxygenated in the lung, pulmonary vein pick it up and carry the blood to the wall, to the left atrium. One thing I want you to also understand in this process, atrium, whether right or left, is always the first place to receive before they give to ventricle. Get it very well. You know, we started from right atrium to the right ventricle to the lung. When it's coming back again, it gets to the wall, left atrium, then it now pumps the oxygenated blood to the left ventricle. Now, the left ventricle is slightly larger than the right ventricle. Of course, that can be explained in terms of its anatomy again, because it receives to be able to do now is the supplier. Left ventricle is the supplier of the body, of the blood to the rest of the body, because it pumps the oxygenated blood to the body. And this is now the pictorial idea. You will not miss this. I did this infograph for you to understand, apart from the picture you are going to see. The oxygenated blood through the superior vena cava, upper part, inferior vena cava, lower part, to the atrium. From the atrium, it gets it into what? Into the right ventricle. Right ventricle through the pulmonary artery. It goes into the lung for oxygenation. From oxygenation there, it goes into the left atrium. Left atrium empty to the left ventricle, which I said is bigger, and left ventricle through the pulmonary vein is now taken to the body. And that's what you see now here in this picture. See the superior vena cava? Here, collects into the right atrium. This inferior vena cava collects into what? Right atrium. From here, the tricuspid valve open. See this valve? Like the gate. I want you to imagine swivel gate in your house. Swivel gate in your house. Without the gate opening, will you have entrance? No. So it opens here now. It opens here now. It goes into what? Into the right ventricle. And from the right ventricle now, it goes through the pulmonary valve. Through the pulmonary artery, it goes into what? Into the lung for oxygenation. And when it gets to the lung for the oxygenation, it now comes out here now to the what? Through the pulmonary vein to what? To the left atrium. And the left, look at those pulmonary veins. They are the one that are bringing the blood now from the lung to the what? To the atrium. And from the atrium now, for it to enter into the left ventricle, it does what? It comes through the mitral valve has to open. And the mitral valve now is the one that will open it into the left ventricle. Blood comes here now, and from there, the blood can now be taken out to the rest of the body. So that is the picture that you see there now. You see them demonstrated in diverse ways unto you, simplified unto you. The oxygenated blood enters in the right side of the heart through the vena cava. It travels into the right atrium, through the tricuspid valve that I explained to you, into the right ventricle, through the pulmonary valve, pulmonary artery to the lungs, and from there, it does what? The blood travels back to the left side of the heart, through the pulmonary veins, into the left atrium, and then the bicuspid valve, the mitral valve. Don't forget where I said you can locate the mitral valve. Can you remember? I told you at the wall, fifth intercostal space, a bit far left. There now. So, okay now, and then through the aortic valve into the systemic circulation. into the systemic circulation. This is now to the lower part of the body. See now, the oxygenated blood coming to the lower part of the body. This is what comes to your body. This is why you see the course, it comes to your body. And this one goes to the neck, goes to the head there now. So nothing goes wrong there for the body to go. If once anything goes wrong, something happens. So we now see this difference on the two sides now. On the right side, you have the superior and inferior vena cava. Then you have the right atrium, you have the tricuspid valve, the right ventricle, pulmonary valve, and pulmonary artery. Now on the left side, because see the blue is for the oxygenated. And that's why strategically you see me putting some icon blue and red here now. I've used that blue for the oxygenated because of course that's what you see when somebody becomes cyanotic. Now, then I use red for oxygenated because the real nature of blood will be shown when when it's red. So for the left side now, left side has to do with oxygenated. That is why it is red. You have the pulmonary vein there, the left atrium, the mitral valve that you saw there now. You saw the mitral valve. The mitral valve is there now. And that shows, that's why you see it far left in the fifth intercostal space. Can you see the location? It's not almost the central left. If you notice the second intercostal space where we pick the pulmonary sand and also where we put the Epps point, you see that they look central to the left side. But when you get to the mitral, it looks what? A bit further to it. That you can picture that around from the anatomy there. Now, of course, these are in systemic circulation. It takes deliver oxygen to the body cell. In the pulmonary circulation, what happens? It eliminates carbon dioxide, fire the lung. That's why the lung is very important. That's why I say cardiopulmonary. Cardiopulmonary, they work side by side. And that's the aorta now, carrying to the neck to supply. Once it gets the oxygenated blood, supplies to the end like that. Let me leave that one. And then the heart valves. Of course, I've talked about the valves already, but let me just highlight some things about them now. They are the door between the chamber. You have already seen them. Let me go back. You have already seen them. These are valves. These are valves. But I don't want you to see it as a real closed door or the one that you lock with key. I want you to see it like a Shiva door. You have seen Shiva door before, a door that once you enter, you should just do like this on its own. Not that you are using key to go. That's the way the valves are. With the pressure coming, they give way to do the work they're supposed to perform. So it open and close to allow blood flow. It prevent backflow. One thing we need to take note is that it prevents backflow of blood. It doesn't allow blood to go in the opposite direction. It's one, if you permit it, it's one-way direction. When you see AV, it's atrioventricular valve. There are two. When you see SL, it is a semilunar valve. There are also two. Now, I've told you about AV valve before. They are also two in number. They exist, and they are in the upper and lower heart chambers too. We have seen the tricuspid valve. Of course, I told you you can pick the tricuspid valve from the which intercostal space now? I told you fourth. Don't forget this. The second intercostal space, left and right. You have the aorta, you have the pulmonary, down Epps point. Below that one, tricuspid valve. Then further down left, fifth intercostal space is the mitral one there now. So that is that for you. And that's how you see it now. You see the way it's like Y shape, thin shape like that. A line flow in only one direction. Now the aortic valve is between the left ventricle and the aorta. The mitral valve is between the left atrium and left ventricle. The pulmonary valve is between the right ventricle and the pulmonary artery, while the tricuspid valve is between the right atrium and the right ventricle. For the semilunar valve, it opens when blood flows out of the ventricle. And through exit, like I said, for the aortic valve, it opens when blood flows out from the left ventricle to the aorta, carrying oxygenated blood. You now see, that's why the picture I brought earlier, you see this aorta, it plays significant role in getting the blood vascularized, oxygenated with oxygenated blood. So for pulmonary valve, it opens when blood flows from the right ventricle to the pulmonary arteries, and only artery carrying the oxygenated blood. Don't forget, little quiz for R2, which only artery carry the oxygenated blood? You should tell me pulmonary artery. Now, let's look at the blood vessels now. The blood vessels, like I said earlier on, is likened to a pump that pump blood from the heart and returning blood to it, and three of them exist. We have arteries which carry the oxygenated blood to the body tissues, except pulmonary artery which goes to the lung. We have vein which carry the oxygenated blood back to the heart, except the pulmonary vein. Then we have the capillary, which are small blood vessels. We have blood exchange oxygenated blood and deoxygenated blood, and this is the way they are. Now look at it. It's like a little tube. Look at the normal cross section of it. When there is vasoconstriction, that leads to that build-up of pressure, which happens in hypertension and the like. You see what happens here now? You see that the lumen is what? The lumen is reduced. When there is vasodilatation, what happens? The lumen is widening. And of course, all this will affect the pressure of blood that is flowing through it. So then, there are types of aneurysm. Aneurysm has to do with outpouring, outpunching of the vessel due to weakened vessel. You know, vessel is not like made of stone. I want you to see it as something that is a bit malleable, not malleable in the sense that I can easily puncture, but pressure on it over time can make it to adopt different posture. And that's why you have about 4 types of aneurysm. You see the fusiton type, the circular type, the dissecting type, and the force type. Now, there are different points in which aneurysm, of course, aneurysm can occur in the brain. And that's why you see some neurosurgical procedure taking place is to essentially attend to this vascular issue that has happened, that has caused damage onto the brain of that particular individual. I've been able to manage our patients in this system before, and I want to tell you that they have good return. I've seen such procedure being done before, and the patient got back to his feet within few days and cool like that. Physiotherapy, of course, was involved there, and that showed the intensity of our intervention in the management of patients. This is to show the different point that you can just see. It's a sort of balloon. Permit us to use that word. Balloon. You see where my cursor is of the vessel. It goes. It's like bulging. Yes, let me use the word bulging. You see a balloon that is you have been using for long. A child has been blowing a balloon for long. You know, it gets to a stage that it doesn't have its normal shape again. It will protrude. Or let's use the aspect of an egg, overcooked egg. You see, when you have an overcooked egg, what happens? The albumen, yes, I think it's the albumen now, burst out of the egg. So that portion that bulged out a little, that is what they call a aneurysm. And there are different points in which it can occur. When you look at the circle of Willis in the brain here now, you look at all these communicating artery. You see the tendency of it about the anterior communicating artery about 40%. And when you see about middle cerebral artery, you see about 2 points, 120% more than, and that's why you almost see the preponderance of MC, what do you call it, middle cerebral artery lesion in a patient. You see it at 2 different points, 20% and 34%. And this one now, for posterior communicating, you have just 4%. So when you begin to talk about where there is a tendency for aneurysm, more on the anterior communicating and the middle cerebral artery area than the posterior communicating artery. Of course, some of these things go undetected in some patients until they are subjected to examination until they are ruptured. But regular checkup may be able to evade that. So coronary arteries actually receive strength from network of coronary arteries that run through the heart surface. The left coronary artery branch into 2, the circumflex artery and the left anterior descending artery. These are the coronary artery there you see now, the branch of the left coronary artery and the branch of the coronary artery of the inferior vena cava. Don't forget that I told you this is the inferior vena cava that collects what? The deoxygenated blood from the body. The superior one is the one that collected the oxygenated blood from the upper part of the body. You shouldn't miss that. Of course, this is the aorta that does all the oxygenated blood now back to the different part of the body. Of course, now you see the plaguing that happens to the vessel from time to time, depending on disease conditions, which I'm going to highlight very soon in some subsequent slide. The plaguing there now is like a deposit You will see palm oil. Some of us have had palm oil in our house before, and in a keg that was kept for long. You now go back to your kitchen, you open the cabinet, you brought out what? The keg. What do you see of the palm oil? The palm oil has gotten what? Sticking to what? To the keg. In some instance, you have to put it on the water, hot water for it to melt. I want you to see that palm oil that is sticking to the keg as this plague. Your keg is the vessel that is there until it is of the interesting thing about the illustration I'm giving is even better because it can be warmed. This one is not like that. When you begin the process, you need a lot of things to happen in the process of time. See now, the major thing now it blocks, it reduces the diameter. And of course, if it does that, you know there's a relationship between radius of vessel and pressure. So it causes increased tension there. So that has to do with all those, and that's what this diagram has been used to explain things out of there. The electrical conduction system controls the beating of the heart. I want us to take note of it. We have the SA node, which I told you earlier on, control the heart action potential. We have the AV node there now. The SA node is the sinusoidal node, which sends signals that makes the heart to beat. The AV nodes, they control, they send signals from the heart, from the upper chamber to the lower chamber. Then we have the left bundle branch, which sends electrical impulse to the left ventricle. We have right bundle branch, which sends electrical impulse to the right ventricle. Then we have what we call Purkinje fibers. And if you notice, I talked about fast action potential. It has to do with the Purkinje fibers. So that's the conducting system and the flow of the action potential from one place to the other. Then we also need to understand the preload and the afterload. Very important factor for us to pick from this now. The preload is the initial stretching of the cardiac muscles, is the contraction. It has to do with what? The ventricular filling. The afterload is the force or load against which the heart has to contract to eject. There are two words we always meet, and that's why you need to pick this: preload, afterload. Afterload has to do with the thing to eject it out. Preload is for you to be what? To fill. Preload, then afterload to get it out of it. So there are two terms very important. And of course, we know our cardiac output to be heart rate times our stroke volume. Very important indices for us to look at. This has to do with the flow of the electrical impulse. I told us about ECG before, where the ECG that is available now is self-reporting. Once it's taken, in those days it will be done, it has to be read by somebody. Each square box has a value attached to it. You not count the number of square boxes to be able to do the reading. But the one we have now is you see the square boxes now here now, but it's self-reporting. What we have actually in ECG is PQRST waves. Now there's a PQ interval, there's PRS, there's PQRS, and then there's T wave there now. So this is the flow of the action potential of the electrical impulse there now. The one I described to you later on can be linked to this now. You see the polarization there to the atrial contract, then giving back to the Q wave. From there we go to the R wave. From there we go to the S wave. Then from there the ST segment of the wave. Then all these are in value, they are in milliseconds, they are self-reporting down there. I want us to have understanding of this volume pressure response to normal respiration and inspiration. And again, this has to do with the linkage between the cardio and the pulmonary now. When there is normal respiration, there is the pulmonary volume is increased. The intrapleural pressure is reduced, and then the intrapleural pressure is reduced. Then the transmural aortic root pressure is increased. And we can now begin to understand what happens when we begin to use some of our interventions in the management of patients. It's beyond, I used to say, it's beyond breathing in, breathing out. A lot of things actually take place here. So for normal expiration now, when you ask the patient expire, breathe out, you begin to see that the pulmonary volume is reduced, then the slow volume is increased. These are the processes that takes place in the body. So when somebody is asking, you just ask the patient to breathe in and out. breathing and out the lung. You interfere with the volume, you interfere with pressure that are intrinsic there that tells the patient to exist very well. Then let's look at heart conditions and disorders now. We begin to go into a bit of myopathies now. The heart disease are leading cause of death worldwide. There's what is called arrhythmia. Arrhythmia is too fast, too slow, or irregular rhythm of the heartbeat. The heartbeat is very, very important. Like I told you, when you are talking in terms of actual potential, even though you see it happening in nerve and muscle, but the one of the heart is faster than that. So, but when you now become unnecessarily fast, it's becoming a pathologic condition. So, cardiomyopathy is unusual thickening and enlargement and stiffening of the heart. It's thickened. I've already showed to you cardiomegaly before we can get it, and now the children won't come. There are different types of cardiomyopathy. There's hypertrophic myopathy, which is inherited type. The left ventricle wall is thickened without abnormal loading conditions. No, I told you preload, I told you afterload. There's also DCM. You see in referral, this is actually a common referral to us to physiotherapy department because the pulmonary unit side, you see DCM. DCM is dilated cardiomyopathy. It is also inherited, it is inherited and acquired. The other one is just inherited, it's not acquired. Both can be inherited. This one can be inherited and acquired. Then we have restrictive cardiomyopathy, also inherited or acquired. And then there is arrhythmogenic cardiomyopathy. This one is inherited. All these are conditions that you can see referral from that say manage as a physiotherapist, and we are going to begin to see something we do later on. Then also we have what we call coronary artery disease, which is plate build up. I've shown us the vessel like that there now, where the intimal layer begin to narrow because of plate build up. Then also congestive heart failure, whereby it is too stiff or too weak for the heart to pump blood throughout the body. I will dwell extensively on congestive heart failure at the second half of my presentation today. Also have issue of diabetes. Then we have a heart attack, an issue of heart attack, myocardial infarction, which is sudden coronary artery blockage, cutting off oxygen to the heart. And then there's heart valve disease. All those valves I told you of, semilunar valve, tricuspid valve, they can also have them. And when they have problem, you now see the gate is locked. When the gate is locked, will there be entrance? That's why the heart cannot be. That's why there's a bigness. You know, I told you it can be big over time. So then there are also high blood pressure, which is a common one. Physiotherapists manage hypertension. They are referred, and there are good results as a result of our intervention. That now there's issue of high cholesterol, too many fats in the blood. There's issue of pericarditis too, inflammation in the heart lining. The heart lining. So there are signs and symptoms of heart condition and disorders. Please, when a patient is complaining of chest pain prior to intervention or during intervention or after intervention, please don't joke with it. Go further and try to do something. If there's a need to do a quick referral for the patient, or to even do a follow-up if you cannot do it, if you want to live in the custody of your junior one or of your co-worker, to please take it to the nearest emergency attention, please do that. They are signal to some things, to some cardiac condition disorder. There's also palpitation, and these are things that we must actually, in our local language, you must actually know how to are going to interpret it to the patient, so that the patient will be able to now give us appropriate feedback, so that these things are not wished away and we can quickly do preventive intervention for them. Also, dizziness is a possibility, shortness of breath, fatigue, lower body swelling. And you look at these signs and symptoms, those are the things you look for when you are managing this kind of patient. You know, I always say management of cardiopulmonary patient is a bit different, because there are some signs and symptoms that are so clear to you that can almost make you to run into some diagnosis, point into something there. The patient is having chest pain, you don't leave that patient alone like that, or begin to subject to procedure, or then heart palpitations. You will explain to the patient, is your heart doing yes, doctor, you are right. That's the way you used to do. That's how you get the cooperation of your patient. Dizziness, shortness of breath, fatigue, lower body swelling. Then let's look at cardiac contributions to brain. Cardiac contributions to brain. There's a linkage. The brain, the heart and brain have bi-directional relationship. You can't talk about brain without talking about heart. I talked about the electrical impulse that comes to the heart. You can't talk about heart and not talk about brain. There's bi-directional relationship with them. And that's why when there's something compromised along the line, like heart disease, it can negatively impact the head brain. Most of these patients that you see coming up is as a result of heart conditions has thrown up. And then the patient can have cognitive decline. And that's why I'm deliberately going to discuss some outcome measures with us today that may look strange to us, but it's within the context of this practice because you will see this in the life of this patient that you are going to manage. Stroke and other neurological issues will happen like that. So cardiac contributions to brain life, they provide oxygen and nutrients, it provides regulation of the heart function via the autonomic nervous system, which controls the heart rate, the blood pressure. Then it has impact on the cardiac conditions. Like studies have shown that heart failure is associated with cognitive impairment, like I told you. And that's why you can't manage a heart patient without assessing the cognitive function. Let me pause there so that you will relate over that. You can't manage a heart condition patient, particularly a failure, without assessing the cognitive impairment, because it's very, very important, particularly if it's a chronic type. Then arterial fibrillation is also linked to high risk of stroke and cognitive decline. Coronary artery disease can also contribute to cognitive decline. You can now see the brain contribution and cardiac contribution to brain. Also, importance of early intervention is very important. Once you early detect early the brain problem, you can easily mitigate what the problem, the heart. If you early detect the heart problem, you can easily mitigate the brain problem. Of course, research is ongoing to better understand all these complex leakages and mechanisms we are talking about. But there is no doubt that heart presentation can most certainly result into heart presentation. And this is the breakdown that has been given by the American Heart Association. American Heart Association at a stage released this out, which is a sort of a scientific statement on the cardiac contribution to heart brain. It's a statement from the American Heart Association that is worth looking at. Genetic factor, early life, look at the early life, then the early adulthood, the socio-cultural behavior, the lifestyle, the vascular risk factors are considered. The middle line, symptomatic cardiovascular risk factor, I told you, can easily be picked up if the adult is also looked at. Then all these are precursor to some things at the other end. But if it's well managed, and this stage of it, the tendency is there. What it can cause, arrhythmia, reduced cardiac output, cerebral hypoperfusion, clinical and covert stroke, which can result from it. And the risk factors, cardiovascular risk factors, which we must always look for: hypertension, diabetes, lifestyle habit, elevated alcohol consumption, smoking, poor sleep, physical exercise, reduced physical activity anyway, unhealthy diet here, and then social determinants of health like low socio-economic status, low educational attainment, poor social support, and then environmental factors. So we'll go to test in heart conditions and disorder, but I want you to stretch your leg once again. Thank you. Stretch your leg for 2 minutes. Stretch your leg. We'll come back. Welcome back. 2 minutes has gone. Let's go ahead. Are we there? Are we there?
Yes, sir.
It's okay. So let's
Yeah,
continue,
we
please. It's okay. Thank you very much. I hope we have some little water there for you to sip. So we continue. So the test in heart conditions and disorders are BP measurement, which you are familiar with, which of course I've taken time to explain today, the right procedure to get it done. ECG too, I've explained it. I've told you about the PQRS wave, the ST wave. I've told you about that one today. The echocardiogram is important there. You ask for this when you see a patient that has heart condition. As for their ECG, like I told you, those things are self-reporting. You see the report there. Echo too is self-reporting, and when you see the echo, you see things like of course, the most significant thing that you look for there is a ejection fraction ratio. EFR, we look at it is in a percentage. Very low ejection fraction ratio is not good for the patient to be able to cope with that. Chest X-ray, very important. I've taught you today on how to do the cardiothoracic ratio and the variant of the younger one and the older one. I've told you, and the issue of cardiomegaly. Then, so 3 things I expect you to ask for patient, which is not beyond you, because you are not the one carrying out that procedure, but it's very relevant to you. The ECG, the echocardiogram, the chest X-ray, and you get the result, you note it down, you put it in the file of the patient to guide you, and also subsequent people that will manage the patient to guide them that these are the things that make you to take a particular decision in the management of that patient. So see other tests, the blood test, the CT, the heart MRI, the stress test, which of course we are relevant there, the cardiac catheterization. Now, this pictorial has explained out what I've explained to you before. Second intercostal space for the aortic valve, pulmonary valve, the second intercostal space for the left side of it, the mitral, the S point, the third intercostal space, then the tricuspid valve, that's the left fourth intercostal space, and the mitral valve, the fifth intercostal space. Let's go to patient examination now. How do we examine? Now, you take the history from the patient. In taking the history, you must be interested in the cardiovascular life of that patient. You ask all those things: what has brought him to you? Any issue of chest pain? What are the tests he has done in the past? If he has the test with you, you want to examine it, that will be a pointer to what is happening. In case it's not, cannot elucidate completely on the condition, on his or her condition. But those things he brings to you will help you to join to what is or is presented to you. And of course, you go to the past medical history. If you say it's hypertensive, for how long has he been hypertensive? Has he been taking his medicine? When did he stop taking his medicine? What precipitated this particular condition? Has it been like that for long? Has it been managed? What has been the response to treatment like that? Then, of course, the drug that is taken, you take note of it. Then the family social is very important. If you see that statement released by the American Heart Society, AHA, on the issue of heart-brain connection, you see that all these things are very important. They are things we're supposed to pay for our history. I had the idea. Very, very significant. Precondition activity level. Very important. That will give you a measure of the what do you call it? Of sedentariness or otherwise of that patient. Of course, if you have things like I didn't include this one here now. If you have something they call 7-day activity record, they will be able to give you the, if that thing has just happened within the last few days, less than a week, that one can even give you a pointer of the activity level of that patient. For that 7-day activity record questionnaire, activities are quantified in MET, metabolic equivalent of tasks. So these are very important. These are cogent direct information that you need from patient that will guide you in the management of the patient. Of course, you go systemic, you go through the cardiovascular, respiratory system, all those things about you to take the blood pressure, the pulse rate, the pulse rate, the pulse score, the respiratory rate, the air entry, the thoracic excursion, the exercise tolerance of the patient. You may want to do it subjectively, and but you can also do it objectively through some of the processes I'm going to still give us later on. Then, because we talk about heart-brain connection, once that happens, of course, it's going to affect You now have to, the neuromuscular system need to be assessed. You need to look at the reflexes, you need to look at the muscle tone, you need to look at the muscle bulk, you need to look at the muscle function and the balance function of the patient. Of course, the joint throughout to see if it has been long. You need to assess the musculoskeletal system, the ARM and the general motor power of the patient. We look at the motor functions there, the motor control, the motor endurance, and the motor speed. You see the relevance of this thing when I begin to break down some things for you, and you assess the balance too of the patient. For patient that has the conditioning that has been taking place, his balance need to be assessed. Both the static and the dynamic balance need to be assessed. Then you go to the integumentary system. Let me pause here. There are some heart conditions that you see some integumentary lesions that are there. Now you still need to take note of it. Don't say why do we need to go into integumentary? Look at the examine the skin. Of course, let the patient be adequately derobed in a place that you can actually see. Then you do gait analysis of the patient too. Very important. You see some things I'm going to teach us very soon there now. Then you now go to because we are physiotherapy, go to the functional ability measures for the patient, whichever one you choose out of what I'm going to tell you, and the special investigation, the lab test, as I've told you about, those X-ray, those CT scan, those MRI, those echo, you report it in your assessment sheet. And even if it's on the EMR too, you put it there. The analysis, you do the analysis of your finding, you come to diagnosis. Diagnosis. Yeah, you come to diagnosis now. Those diagnoses may reflect like that. It may become like that. It may become like impaired motor function secondary to heart disease. Or it may be impaired respiratory performance, respiratory function secondary to heart disease, as you can see in a heart failure, whether left-sided or right-sided. Those are the kind of diagnoses you come with. The treatment plan, do the education of the patient and appointment. So we go into some outcome measures now. I begin to throw at us. So of course, you know the GCS, Glasgow Coma Scale. Some of these patients we are talking about here now may be on admission. So that is why it's very important. Don't let your mind quickly flip to our patient. No, let your mind also flip to all the scenario that asks to surround the patient. So you do the GCS of the patient there, and then you categorize it whether it's mild conscious or moderate conscious or is severe conscious. When your score is between 3 and 8, it's severe. When it's between 9 to 12, it's moderate. When it's between 13 to 15, it's mild. Then from there, we go to different outcome measures. I'm going to waste time here so that from now, you become a master of all these things. They are there for you to refer to. Even though there's one particular one I will instruct you, don't use it anyhow, just for teaching purpose that I'm using it for here. And just keep it for teaching purpose. Let's begin to give to it. Now, there are things like 6-minute walk test. There's walk test. So all this one I've listed here now, I'll begin to go into them one after the other. This is I told you there's a possibility of cognitive issue in patient. I hope you remember that. So you assess that through hospital. There's also the issue of anxiety and depression. For cognitive, I'm still going to attend to it through one scale later on. There's a possibility of anxiety and depression. So here now, this is a 3-in-1 form. It's called hospital anxiety and depression scale form. Each of those things, you see, the yellow one has to do with anxiety. Those are yellow questions. The other one that is not colored, they have to do with depression. Now, the scoring is over 21 for each of them. So there's anxiety, hospital anxiety scale for the yellow one. Then for the one that is not colored, hospital depression, so each of them is over 21. Each of them is over 21. So the score now, you see, it's not just scoring. There's interpretation of score. When you do all this score now, whether if it's yes, it is 3, definitely yes, yes, definitely 3, yes, sometimes true, no, not much 1, no, not 1, 2. These are things that can easily be administered on patient. If you have any inquiry about this, you can always inbox me. I will be available for you to guide you further on it and go like that. So by the time you do the summative of the score, you do it over 21 now. Grading, so 0 to 7 is no problem at all. No non-case. Now 8 to 10 is borderline case. There's borderline issue of anxiety or borderline issue of depression. And of course, the 11 plus is case. And you know, of course, if this happens, you know what it means to your management. It means some other person has to come into the management of your patient. Not that you are receding out, but somebody will still have to come into the management of your patient to be able to appropriate referral. Or if that referral has not been put, you can point the other team members to it that this is what I discovered. I think this patient needs to be referred for further management by psychiatrists or the like. Then the patient I told you may also be on admission. So you may use things like ICU mobility scale. Very simple, very simple. And you can see it there now. There's no doubt that this is very relevant to us. It is on a scale 0 to 10. It has to do with progressive increase in physical function of the patient from 0 to 10. 0 is nothing. The patient is lying on bed. I told you a patient can come in like that. We have seen that before. Then 1 is sitting in bed, exercise in bed. Then you just begin to see a patient you pick from 0 as you begin to administer this patient is now 3. After some days again, the patient is 6. This is objective reporting of the patient. And then finally, there now 10 is working independently without aid. 8 there is working with assistance of one person. I don't want us to jump into this, and I don't want us to jump any of this level. Please, when a patient is not yet fit for 7, when a patient is still supposed to be at level of 7, working with assistance or trauma, don't let the patient be operating as if should be 9. You know what that means already. So let me leave that one. Of course, the rate of passive exertion, very, very important here now, because one of the things that they present with is breathlessness. We still see when I begin to explore into the heart failure, we see something that is breathlessness or over-exertion. Here now, so what you can do, of course, I know there are different versions of this anyway. Some can score up to 20, but this particular version that has been put here now, the RPE, is 1 to 10. 1 is a very light activity, hardly or any exertion, but more than sleeping, watching TV. 2 to 3, there's light activity. Then 4 to 6, there's moderate activity, breathing heavily. 7 to 8, vigorous. By the time a patient begins to get to 7 to 8, you know the patient begins to get better. This is objective reporting of the patient. The patient came here with you started managing your patient with 1 of RPE, hardly any exertion, but more than sleeping and this. And then later on, the patient now is 10, feels almost impossible for going out. Then you know it's depreciating. It's depreciating. But when the patient can tolerate more, you mean the patient is getting better. Now, there's what is called HRV. HRV has to do with heart rate variability. Heart rate variability. This has to do with the fluctuation in the time interval between beats. I told you there's a beating. And the heart is beating as you are hearing this man. So there is a fluctuation in time interval between the heartbeat. It's a measure of the interplay between the sympathetic and parasympathetic, really. It is beyond the figure that is peak. It's a function of the nervous system. And you now see the brain, what I call the brain and heart connection there again. And the higher HRV actually generally indicates better resilience. When an individual has higher HRV, that patient, that particular individual, whether patient or an individual, can cope with stress, better resilience of stress. You now see how, as physiotherapists, we can step up our practice to a level that we reckon with well in the management of a lot of things, like that in stress management. You say, okay, your HRV is what? Oh, it's high. Oh, you'll be a better performer, you'll be able to cope well with stress. But somebody that is HRV, heart rate variability, is low, you also see the implication of it very soon. So what it reflects is this. The variation is influenced by the autonomic nervous system, like I said. Please take note of it. When it is high, the individual will have good physical fitness. Take note of it. When it's high, the individual will have good physical fitness. It indicates good physical fitness, and the person has balanced autonomic nervous system, ANS. Now, when it is low, the patient is a sign of stress, and the individual will not be able to sleep. There will be lack of exercise, and there will be underlying health issues. You now see how it's related to us. These are figures that shows a lot of professionalism in our practice when we talk about now. Factors that influence is that age, sex, fitness, genetic, lifestyle, like stress, like you have also seen there. Of course, just some lifestyle factors actually affect it. Now, it's been shown that issue of intermittent fasting can improve heart rate variability. That's a good note. for people that fast, but that's also a positive thing to lean on in living a healthy cardiovascular life. HRV, the heart rate variability, will be positively influenced by fasting. Also, changes occur during the day. It is advisable that HRV is done in the morning. First measure in the morning before a lot of variables begin to come inside that will make it to be inconsistent. Of course, it ranges from 20 to 200 million in healthy adults. Younger healthy adults tend to have higher HRV. It must be noted. Once somebody is younger, once he's healthy, will have higher one. The person will have good fitness, cope with stress. But once somebody is not healthy, these are indices that come. But how can it be taken? Most subjective way is also through ECG. ECG will give that report out. Then another way of doing it, which is also beginning to show now, is I don't want this to be straight to you. That's why I have to teach this today. Then you see PPG. PPG has to do with photoplenphomography. It's a smart way, a quick way of getting this done. And also, there are some machines that can be used. If you see some of our machines, they come with chest strap monitors. They can give those information for you. Chest strap monitors. Some of our, like we have a system here now. Some of the things we have a ergometer, have chest strap that when you put it on, it will be that sensor. Yeah, if you put it on immediately, you may need to put water and salt to the inner side of it that will be lying on the skin for it to be sensitive. But after some time, if you don't do that, the sweat will be able to pick the signal like that. So that is there. Also, some wristwatch can have it. Some smartphone cameras can have it reporting this HRV. But like I told you, the ECG is the best method of getting this done. And that's what you see there now. You see the variability there now, the high one and the low one that is typified in that this that we are talking about. You see that low one, low value, high value. I told you the variation in the heartbeat from time to time is what is called HRV. So you have added another vocabulary to your cardiovascular assessment today, HRV. Now, because of the tendency of the heart-brain connection, and I told you balance may be distorted, there is this SPPB that can be used. This has to be a short battery test that can be used on patient too. These are simple process, but this is a bit long. It takes some few minutes to get it done. You can do the balance aspect is there, the gate speed is there, the chair stand is there for us to use to be able to assess the patient. And the purpose of it, this short battery protocol that we administer on the patient, is to identify individuals that are at risk of disability, fall, and mobility. I told you because they have not been moving for some time. You will still see the heart failure issue now. There's a tendency for these things we are talking about to be compromised for this particular patient. And because of that, this has to be measured for them. So in this short physical performance battery protocol score sheet, we go through the balance test. There's side-by-side standing that will be done for the patient. There are questions that you ask the patient. They are self-explanatory there. Then there's self-tandem stand that can be done for the patient. The tandem stand too can be done for the patient. Then this are the scoring that can be adopted. If the participant did not attempt test or failed, circle, tried but unable, 1. That's why you see the scoring in front of them, side by side standing, semi-standing, tandem standing, you see all the scoring there now. And then the gate speed test, you see the scoring. The second gate speed test, you see the scoring there now. And also, it continues like that. The first gate speed test, all of them continue like that till the end. Then finally, the scores will now be put together. Total score, test score by the patient, the gate test score is done, the chart test score, and this is monitored from time to time. They are simple procedure to administer on the patient. How the patient stand with the chair, how the patient is going to walk, how the speed is rated, they are done. And these are the way it is now. These are things you can pick up and begin to administer on your patient. Now, there is also St. Gregory Respiratory Questionnaire. St. Gregory Respiratory Questionnaire developed by St. George, not St. Gregory, St. George's Respiratory Questionnaire developed by St. George's University of London is very, very important. You may begin to wonder, we are not discussing respiration today. Fine. But I've told you, anything that affects heart, affects what? Lung. Anything that affects heart can affect brain. So you are not speaking amiss when you begin to put all those things together. You are talking holistically concerning the patient. So, but the interesting thing now is that St. George University of London has been able to go further beyond the respiration alone. There's another component of it that is for left ventricular dysfunction. That one is called left ventricular dysfunction questionnaire, LVD 36. So these two can also be administered to monitor patients. Now the question somebody may also want to ask is that St. John's respiratory questionnaire was initially developed for asthma and COPD, but they've been and also been used somehow for bronchiectasis and also some interstitial lung disease ILD. But it has also been shown now that it can be used in some cardiovascular problem, like in hypertension, in pulmonary hypertension. So finding not strange when it's administered for this purpose. But the good thing there is that this can be used. Also the left ventricular dysfunction questionnaire can also be used to be able to help patients. This is the I deliberately highlighted left ventricular dysfunction questionnaire LVD 36 is actually not bogus. It's just a page, as you can see it on this slide 107. It's a true or false scenario that you ask is when you ask the patient, do you feel exhausted? These are things that, I told you there's a classical way in which you catch this patient. The classical way you ask this patient is that, how is their activity like? Have they found something difficult to do? We said, do they struggle to cope with their life? When they say struggle to cope with their life, we are not talking in terms of finances now. I'm talking about ability to do. Is it there? Is it compromised? This is all what it's all about. And the answer is yes or no, and you go through like that. So that settles that there now. So we'll be able to assess for respiration, we'll be able to assess for some abilities, we'll be able to assess for some ventricular function. Then I also told you that there's a possibility for cognitive decline. I hope you remember that in some of these patients. So because of that, Minnesota living with heart failure questionnaire is also very important. This is been validated too, and then it's recommended people use it. The scoring is friendly, it's something that can easily be administered. The total score is calculated by summing the responses to all the questions, and then there's a questionnaire attached to it. That's the one I told you that please, I'm just using this for the illustration of teaching. Don't use it beyond this purpose for any expensive thing giving it out. I deliberately want to bring it for you to teach you, not for you to give it out, but I want you to be aware of this. There is a simple procedure that can 21 questions, and then you rate it, you get the score for the patient, but please let it not be beyond the ball. The condition of cognition is very important. Also known as physiotherapist, this determines a lot of things. A patient that is not having good cognitive function, how will he cope with your protocol? How will he cope with your condition? And you just be wondering what will result. He's not doing as much as you do. It's even better when he's with you. You can use your presence effect to do. But when he's at home, how will he be able to cope with home? He will not be able to perform as supposed to do. So because of that, we need to assess this. And our MLHFQ is very, very important in this respect to be used to assess the cognition of the patient. Like I said, please don't take this out of the context of this practice. Don't say that this is not for this. It is part of the assessment you're supposed to do, because your patients have that tendency. It's been reported in studies that they can have this kind of challenge. Then there's also a self-efficacy scale. Self-efficacy scale is a tool that has to do with the ability to organize and execute a course of action by the individual. Of course, there are different types of self-efficacy scale. The one I'm bringing to bear here has to do the general self-efficacy scale. There's self-efficacy, there's general self-efficacy, there's what has to do with arthritis, that one is arthritis self-efficacy scale, access. But if you can beat this general self-efficacy is very important, because I told you the challenges people are having. is their ability to cope with their daily tasks. So it needs to be measured. It needs to be reported from time to time. And that's the word you see on the score. There's also see it's friendly. It's something that can be done within some less than 5 minutes. There now, that be done. Then you score. Not at all true, hardly true, and co. The scoring system is noted there. Not at all true is 1. Hardly true is 2. Moderately true is 3. Exactly true is 4. Then you pick this. I'm sure less than 5 minutes you'll be able to go through it. Of course, some of them, if you cannot get through with all this I've told you, and use the type up and go system for the scoring of the patient. And of course, you know here you need a tape measure, you need the armchair, you need the stopwatch to be able to get this, and you need the marking chair put at the two ends, and the patient walk from one chair to and come back to that same chair. And then if the interpretation is there, if it's less than 10 seconds, it will be normal. Of course, you know because they are mobility impaired. This has happened to the heart, which is manifested across system. They are the gates of which I told you earlier on will be mentioned, will be slow. And will be slow, you expect that the time they are going to report here, will it be low or high? It will be high. It will be high, yes, because they can't move very fast. So the time will be what? Will be high. That's why you see there now that when we say when it is less than 30 seconds, it cannot go outside. It has interpretation beyond figure. It means they cannot go outside. Of course, I'm going to discuss something on gates too very soon. Because for somebody that cannot move very fast, there's implication for it. You have to guide or you have to watch the movement of that person. So that introduces us to gait speed, which assesses individual functional mobility, being a predictor of decline in functional mobility. Let me put it on record here now that issue of gait is very vital and it cuts across patient management. The speed has to be assessed because it's a strong indicator of the mobility of that particular individual and also the risk that patient may have, that individual may have, and potential for hospitalization. So it's better it's quickly measured, quantified, and monitored over time. Of course, the higher the speed, the higher the speed, what do you think it will happen? If the speed begin to get to, if the speed of a patient is sluggish, what will be the effect on the patient? I want answer from you now. Answer. What will be the effect? Before we go on another break, if the patient's speed is sluggish, the patient is walking sluggishly, let me not quantify it now in a figure. What do you expect? Oh yeah, open your microphone and talk to me. What do you expect if a patient is walking sluggishly? Is he at risk or is not at risk?
At risk.
It's at risk, yes. That's why we need to measure this. And that's why you see in that TUG, you expect that the time will be high. But somebody that is not mobility impaired, the speed will be low. So we move on. Thank you, because you have gotten that. Let's move on. So, and this is now the aspect of the gate speed too again. Oh, sorry, I've not picked that one. The gate speed, it is all on its own. It has its own interpretation. You see there now that greater than 1 meter per second is predictive of completing yard work. You can climb stairs. It has its own meaning. Now, when you take 1 meter per second for prevention, and you need to include that as part of the protocol we are going to use for the patient. Now, when the patient is at is like a 0.4 meter per second, the longer length of stay in acute care for that patient, it will still be in an admission to be taken care of or be in a nursing home. These are the beyond figure. These are the interpretation of it. Most probably the speed of a patient is impaired. It's a signal to the management of course, some of them may not be able to get out of bed. You know, I told you the one in ICU. And now they are still impaired in one way or the other. We need to do some TCT for them, throat control test. And that one is only in 4 domains. and that has to do with either I can roll from the weak side or the strong side, holding sitting 30 seconds, able to sit up from supine to sitting. And each of those ones is maximum score of 25, 25. And that's why 25 times 4, 100. So the maximum obtainable here is 100, but it's not all instant. A patient that is still on the bed cannot get up is 0/100. Yes. So if you can be able to do zero, if you cannot be able to do zero, if it's able to do with assistant 12 for each of the domain, if it's able to do without assistant 25, able to do everything 100, 100, but able to do with assistant which is none of them, 12 times 4, that's 48/100. It's still difficult. There is still part of the management side that are going to attend to the patient. Of course, CAS score, this is a very simple one. If you don't want to go through the elaborate one that I've gotten into 6 times, about 10 pages for those other ones, you can use this one. This is just 6 pages, six domain. Have to do with bathing, can you bath, can you dress, can you toileting, can you transfer continent. Don't please, like I said, let me repeat myself. Don't find it straight that this has to be measured in this kind of patient, because they suffer from the conditioning process and then they will lose some abilities. Now, I will talk earlier on about DVT. But I deliberately left it at this end as part of the outcome measure. I would have brought it much earlier on in the presentation. I left it at this end so that we'll consider it alongside the other outcome measure. DVT, I told you, is a possibility purely a cardiovascular problem, but more relevant in cardiovascular conditions. Now, this is what they call two-level well score. DVT well score. DVT well score. This is how it is done. Now, it's a very simple process. Attention with 1 mark like that, and the last one -2 like that. Now, the first one is when there's active cancer in a patient. People in palliative may stress them now. Treatment ongoing within 6 months of palliative, that person will have score 1. Then paralysis, paresis, or recent plaster mobilization 1. You know, across specialty, you can see how it can be relevant to us. Of course, some of these things have been reported in some other things there now. Then recently bedridden for 3 days or more, or major surgery within 12 weeks, requiring general regional anesthesia, the person will score 1. Localized tenderness along the distribution of the deep venous pain. You know, I've already traced it for you. When I was also distributing it with from cellulitis for you. Now, it's 1. The entire leg swelling is 1. Then previous documented DVT 1. When all these things are summed up, DVT is likely when there is 2 points or more. Now, DVT is unlikely when there is 1 point or less. This is a very simple process. So your diagnosis, if it is more than 2 now, your physical diagnosis will be impaired vascular integrity. Hello?
Aye.
Are we there? Yes. It's impaired vascular integrity. Something is already going on. Of course, yes. Of course, you now have to remeasure over time. So please let your score be handy with you. I would suggest go and paste it somewhere. When you get to my department, I pasted it in some places from time to time. I remember I was somewhere sometimes ago, some people were discussing something to say, yes, my department is here, place it somewhere, and something that we take into consideration in the management of our patient. It's time for you to go now to go and stretch your leg. We'll come back in another 3 minutes. Please go and stretch your leg. Thank you. welcome back. Are we here?
Yes, sir.
Are we here?
Yes, sir.
Yes,
We are
sir.
here.
Yes, sir, we are here.
Are we there?
Yes, sir.
Yes, sir. We are here.
Yes, sir.
I'm sorry, I had some network issue. I'm back. Are we together?
Okay, sir. Thank you. Yes.
Yes, sir.
It's okay. Thank you. Sorry, please, for some 2-3 minutes. My network cut off. Thank
Yes,
you.
sir.
So let me move on. By 1:30, I should be able to give us about 15 minutes break. But let me move on for the next 37 minutes. Now, we go to Pitin Odima. these are things in a what do you call it, in a heart failure. You see edema 2 occurring, and then you need to be graded. Even in some DBT2, you see it occurring, so you need to be graded. It's on score +1, +2, +3, +4. +1, there's 2 mm depression, just like you see it as is illustrated. These are very self-explanatory, something you should be able to replicate. You see the depression there, the first depression there now, just 2 mm depression there, barely detectable. Immediately you remove your hand, it bounces back. That has to do with +1. Then +2 is when it's maybe more deeper, that is 4 mm. A few seconds in the band. Then it is the other one is more deeper, that's 6 mm. That one will actually take 10 to 12 seconds to rebound. Then 4+, it is much deeper, it's 8 mm, and it's very deep, and it takes more than 20 seconds to rebound. This also will help you to monitor progress of the patient in the issue of edema vis-a-vis the integumentary system of the patient. So that is that easily pickable. We call it pitting edema grading. Like I told you, you can use it in DVT. You can also use it. You can also use it in heart failure conditions that I'm going to discuss with us very soon. Then this is the cognitive one. Like I told you, there's a possibility of cognitive impairment in these patients that we are discussing. So there's this Montreal cognitive assessment tool, which has been brought over here for us to use. You can easily pick it. It has to do purely with the issue of cognition, which I told you is reported because of this heart-brain connection that we have examined together in the course of this presentation. It's actually a one-page document as you see it. It's a 30-point test. You need just about 10 minutes to be able to get it done. And the score of 26 or above is generally considered normal, while a score of 25 or less may indicate some degree of cognitive impairment. So the advantage of it is that it's very simple and brief, as you can see there. I can tell you that it's very, very sensitive when it talks about issue of mild cognitive impairment, and it's an objective test there. You see there simple scoring. Maybe recalling the issue of orientation of the patient, either you know the day, the month, the year, the day, the place and city, the delayed recall, whether the patient can recall back what he can see, and the language too, the attention, the memory there. The patient can also be able to identify, name any of these animals. He will not call lion to be goat and goat to be hen. These are ways of assessing our cognition. Like I told you, it's a simple way to go through it. It's a 30-point. Any score of 36 or above, generally considered normal. While a score of 25 or less, you see, can't explain, a little drop. The total score, once it's less than 25 or less, it indicates some degree of cognitive impairment. And you fathom that into management, and also fathom that into if there is a need to be referred or for some other professional to handle or not. So having done extensively with issue of outcome measures, even though along the line, I will go into some things especially related to cardiac very soon. But let me begin to delve into CHF now, which is one of those disorders I've told us about. That is congestive heart failure. This is the congestive heart failure, the way it does. It has initially, earlier on, I told you about the echocardiogram that you should be interested in it. And I told you when you pick it, one of the things you should be interested in, apart from the thickening of the walls, is the issue of AFR, ejection fraction ratio. So the diagnosis of heart failure has to do with whether the ejection fraction ratio is reduced or is preserved. When there is reduced ejection fraction ratio, the heart can't pump or squeeze enough blood out to the body. Yes, it cannot pump or reduce pump the body, and then in some instances it may need urgent intervention for the patient. It may even be surgical. I remember when I was out of the country on my specialized training, I was exposed to this and also even to the surgical procedure. In fact, I was there for almost about 12-hour surgery for the cardiac surgery for the patient. You see the ejection fraction ratio of that guy. And interestingly, he was just I think was it 29-year-old? Yes, 29-year-old. 29-year-old. He was South African. He came from Africa over to the place for the medical intervention. And that's to you that we have medical tourism is real. I happen to have met him and happen to have been part of this procedure. So you see it now. All those things I told you earlier on that the body will not get enough nutrients. See, the guy was skinning. This skinning I'm using now is in clinical context is not an abusive one. It's to show to you what has gone wrong, that his body has not been able to cope with what it's supposed to do because of that issue of pumping of the heart. So of course it was I think he had mitral valve replacement, MVR, there. See how Victoria, some of them, I may not be able to show it to you here now. We went about all those things. So it is free. The surgical procedure is free. Our intervention is also free. It's something that has been helping people. Even though years before that time, I've had cost to manage one other person like that has the issue of heart condition or for a particular protocol that was prescribed for that person to go. And that person lived long years. The person lived up to 90 years or so before the person is. So what we are talking about there is real, that is seen in patients. We're just trying now to pass it across to us that are to have adequate knowledge about it and how we are going to go about the management. So it has to do with either the ejection fraction ratio is preserved or it's not preserved. If it's reduced, the heart can't pump or squeeze enough blood out of the body. But if it is preserved, the heart can't fill with enough blood. Can you see the two extremes? In the first instance, it can't pump or squeeze enough blood out. The other instance, it cannot fill. If it doesn't feel enough, what is it going to take out? So, and that's assessment of this we saw life. How is it with his life? once again. Network me out. I hope we are together. Are we there?
Yes, sir, we are.
We are here.
Are we there?
We are with you.
We are here, sir.
Yes, we are.
We are here, sir.
Sorry, he's having a network issue, but he will soon rejoin. Sorry, he's still trying to reconnect. Give him some few minutes.
I suggest if we should go on break.
Be back. Hello. Hello. Please, I'm the one speaking. We can go on break. Let's convey back at 1:35.
Okay.
1:35, please. Let's go on break. I will sort it out before that time. I'm using the physical presence phone person now.
Okay. Thank you.
Okay, so.
We are starting in the next 1 minute. Well, welcome back from the break. Sorry for the issue that we had in network. I had to switch to another system. Are you hearing me?
Yes, sir.
It's okay. Thank you very much. You are welcome back. I hope you have taken some water.
Yes, sir.
And you have stretched your leg. It's okay. So let's move on. Let's move on. We were on the issue of the heart failure before the network issue came up, and then we went on the short break. So we are considering now, and we are seeing some clinical features that is expected. We've looked at the picture of the normal heart, quite a bit different from the picture, the illustration that we've had so far. And we've also seen the enlarged one in failure. We've seen the picture of an individual that is presented with a congestive heart failure, what you would see. And you now you see the issue of the fluid around the lungs. That's why I told you that when we are considering the outcome measure, still the relevance of St. Gregory outcome measure, even though there's left ventricular dysfunction outcome measure. So then we see the bloated stomach also as part of the presentation, and then the swollen and the cyanotic feet that you see there. Of course, all the outcome measures that we've shown up this afternoon will be relevant in being able to manage this patient. But you see the classical presentation, the swollen and the swollen leg, not only swollen one, the cyanotic one, because it's already desoxygenated blood now that is there. Of course, this will be actually more noticeable
in the light in complexion, but even in the dark one too, you notice the change in coloration of the skin. So when you talk about congestive heart failure, what it's all about is that it's a long-time condition in which the heart can't pump well enough to meet the demand of the body. Imagine having a 500 ml tank in a 10-bedroom bungalow. You see that you will not be able to cope with it. Or you even still have 20,000 capacity tank in the house, but the pipe connecting into the house is blocked. You see that I'm using this one as illustration, you will not be able to actually cater for the house. That is essentially what is happening here in the case of failure. And the pathophysiology has to do with the weak pump there, and the pressure in the heart increases in the work. In the process, the ventricle begin to overwork. Well, there's no glory, there is no benefit in overwork. In the overwork in this instance now, it's just like you as an individual. If you overwork, you are going to be fatigued. That's essentially what is happening. And there's build-up of the fluid. That is congestion with the fluid. But the interesting thing is that just like I told you that we have our 4 chambers of the heart, we have the upper one, we have the lower one. So also when there is heart failure, there are types. There's left-sided heart failure, there's right-sided heart failure. There's a difference in presentation, there's a difference in them. The left heart failure, when it will be written like this, LHF or RHF. LHF, left heart failure, or they may say LVHF, left ventricular heart failure, or right ventricular heart failure. That may be written like that. So when left ventricle can't pump blood out of the heart forward so the blood backflows, that is when there's a left heart failure. When the left ventricle cannot pump the blood out of the heart, so there is a backflow. You know, I told you that the normal flow is what? A unit that the forward direction. But there could be a situation in which there is backflow. So in this instance, this is what we have as a left heart failure. So, and there is a backflow into the lung. And that is why there is issue of pulmonary edema there. Then there's right-sided heart failure. In this instance, it is the right ventricle. Notice the nomenclature. Left heart failure, left ventricle, right heart failure, right ventricle. In the right heart failure, the right ventricle cannot pump blood out of the heart forward. So, you know, I told you the right ventricle blood goes to where? If you can answer, it goes to where? To where?
To the lungs.
It's okay. That's a good one. You have been following. So in this instance, the right ventricle can pump blood from the heart forward. So the blood backflows peripherally. And that is why there's this issue of peripheral edema, to which I told us we can score. So these are the signs, the different signs of the left side and the right and the right side. For the left side, there are crackles, which of course we have to do with auscultation, where the context of this lecture will not make me to go into the issue of bronchopulmonary segment. For people that have good understanding of bronchopulmonary segment, you know, you move from one segment to the other to be able to do the ear entry auscultation for the patient. So there is a tendency for crackles here. That's why you can't do the examination of this cardiovascular system without also looking at the lung. That's why you see there. Now, even though we are not essentially looking at a respiratory problem, but because of that, their connectivity, they feed the lung bring it back, and something is fishy in the process. So the lung too is compromised in the process. So there's crackle there. Then there's dry cough, there's tachypnea, there's a pulmonary congestion there. So for the left for the right heart failure, which is the systemic one, then the extremities, there's edema there. There's abdominal distension, like you saw there. There's a jugular venous distension. When you check the angle, the triangle by the side of your neck, there, you see a prominence there that see something is bulging out. That is what is known as a jugular venous distension. Once there is jugular venous distension, we talk in terms of a right-sided heart failure. Of course, there will also be weight gain. There will be hepatomegaly. There will be splenomegaly. Other things have been taken care in terms of echo and also stress test. The stress factors are things like diabetes, hypertension, myocarditis, endocarditis, and also the cardiomyopathy that I've told us earlier on. And then the causes, I told you those valves, if they are faulty, there will be issue of backflow. Ideally, it's supposed to be one direction, but in this instance now, because they are faulty, there will be a backflow there. Also, genetic is there, which of course I've traced out for us in the other time. So this to do another a bit of explanation again to it. The right-sided, the heart is too weak to pump enough for the oxygenated blood to the lung. Then the left-sided, the heart can't pump enough oxygenated blood to the body. You see, it's a serious dilemma in this instance now. So too weak to pump enough blood out to the lung, too weak to pump enough out to the body. I want to test you now. When there is too weak to pump enough blood to the body, which type of heart failure is that?
Left-sided heart failure.
That's good. So we move on. So when we see the issue of diminished cardiac output, and once there is diminished cardiac output, there will be inadequate peripheral tissue perfusion. And you also know that I took a time to teach us on mean arterial pressure today. And I told you that once it's under, the organs will not be well perfused. The same thing happens in this instance when the heart is having a challenge. There's congestion of the lung, and the periphery may also occur, and the client may develop acute peripheral edema, like we said earlier on. Now, I want you to take note of ejection fraction ratio. I've been discussing it, and I told you it's one of the things you need to look out for when there's echo results from patient. Your patient bring it. If you have anything you didn't pick from there, just look out for that. Even though there's many things on the septum, the thickening of the ventricle, those things will be indicated. But this particular one, don't miss it. Ejection fraction ratio there, because it's actually used to diagnose the issue of heart failure. Now, that's what I'm going into now. The left-sided heart failure, there are two types. There's systolic heart failure. This is the kind of heart failure with reduced ejection fraction ratio. They will write it HF small r EV. When you see small r before EV, it means reduced ejection fraction ratio. When you see small p before EF, it means preserved. It can either be reduced or preserved. So now, when it is reduced and it pumps at less than 40%, that is what is called systolic heart failure. That's the left one. But there can also be diastolic heart failure for the left side. When there's preserved ejection, you see it there now, HF, PEF, but it pumps at greater than 50%. Then there's a middle range one. The middle range one is between 41 to 49%. Participant online, please, this is diagnostic of heart failure. This is the way it comes for. You will see some positional statements, documents that have been issued out by American Heart Society, Cardiology Society, like that have brought out doing this categorization. In fact, the next few slides, you see it, I'm beating it from one direction to be able to pass the information across the road that this is the way in which it's diagnosed. You pick it. And then you now see it in our own climb, what it has caused the patient that will now make us to intervene in his or her condition. Like I said, it could be preserved, it could be reduced, it could be middle range. So for the left-sided heart failure, it is categorized in these two ways. So myocardial dysfunction, there could be systolic dysfunction in which the left ventricle has reduced muscle contractility. There could be diastolic one in which there is decreased left ventricular filling caused by ventricular stiffness. You see, there's a way the muscle of course, just like in the colloquial musculoskeletal too, the stiffness of the joint is not preferable. The stiffness of our muscle is not, that's why we do our stretches. The stiffness of the muscle is of no really beneficial effect at all. So when the ventricle too becomes stiff, there is increased rate of exertion, and that's why you see rapid heart rate. It's working forcefully. It's just like a car that is not firing very well. You see the way it's going to look. So this is a pictorial representation of them, the one that cannot supply enough, the one that can supply enough. Now, let's go to the right-sided, and I said that one too. The right-sided ventricular heart failure occurs as a result of left-sided failure. It's a follow-up to it. So when the left ventricle fails and can't pour enough blood out, that increases the pressure that is transferred back through the lung. So there's a tendency for double failure. That is what is bringing out. Of course, this is normal when you begin to see the EF. Normal range between 55 to 70%. Then when it's between 40 to 55%, is below normal heart function. When it's higher than 75%, it can indicate a heart condition with hypertrophic cardiomyopathy, like the one that's. And when it's below 40%, it may confirm heart failure. Of course, okay, this further explains it out. Now, epidemiology of congestive heart failure. Please don't forget ejection fraction ratio, whether preserved, whether it's preserved middle range. We talk about left ventricle, left heart failure. So epidemiology now, actually, congestive heart failure increases with age. Even though you see some cases in some younger ones, 1 to 2% of the population are less than 55 years, and there's increased rate of 10% for people that are older than 75 years. Though it can occur on any age, like I've seen, you've seen some instances I've given unto you, it's actually some younger people. Now, the epidemiology, still talking about the epidemiology, we have actually sizable population in America, 6.9 million Americans that are greater than 20 years of age that have this CHF, and this is expected to rise to 8.5 million by 2030. By a study done about less than 2 years ago or thereabout. Of course, that can be linked to the issue of the lifestyle, factor in people, and also beyond lifestyle, also the technological advancement, physical inactivity. People are condemned to sit by system. There's some things that are supposed to be done for them are being done by system, so less active. So there's a tendency for this less blood flow. So, and also estimated 960,000 new chronic heart failure are expected annually. And worldwide, 64 million people, greater than 64 million people worldwide are having this. And that shows to you that we have a lot of work to do. And that's why I keep saying with all boldness that physiotherapy will never go out of relevance in medical practice, in clinical practice, because we have the population here and there to deal with. It's just to fix it into this population and doing our stuff and help our society and move on. Of course, there is a substantial morbidity and a mortality in this condition, because it actually can be, if it's not well picked up in time, it can be things that can cause death of the person, and can cause the person to be immobile, just like you see the previous assessment that I talked about. Talking about this in Africa here, the cardiovascular disease account for 7 to 10% of all the medical admission to our hospitals. I've once presided over an large unit before, and I see the volume of course, at a stage when we raised some campaign, we started getting some volume of referral that we hardly could cope with because of the new of our hands that is on hand. So we really have a lot of work to do. We have a lot of population to deal with, and there is something that is actually common to take care of. So in Kenya, and 32% have a rheumatoid heart disease, and constitutive factor which is a contributing factor for the heart failure. Out of these, 25.2 are the cardiomyopathy, the different type that I told you about there. Don't forget, I told you maybe DCM, you will be written in referral. I've told you the meaning of that. Then 17% has hypertensive heart disease. 32%, 13.2% has pericardial disease. And then when you now come to our, also still in East Africa, 1 in 7 people is affected by this condition. It seems to be common in their climb there, and particularly in Kenya, associated factors with patient deterioration leading to admission with chronic heart failure. So inadequate therapy, arrhythmia, respiratory infection, anemia, infective endocarditis. So our colleagues over in that climb will have a lot of work to do. And also neighboring Ghana here is not spared. Hypertension 46 to 46.5%, and a previous history of heart failure 38.6%. And the dilated cardiomyopathy, DCM, accounted for 38.6%. And then we will come back to our own client here, Nigeria. We know most of the commonest cause of cardiac heart failure in a study done in Abuja, there is hypertension, and that's accounted to 61.5%. And this was as at 2009 anyway, and that's 16 years ago. We know that the figure probably are changing. And that of Abeokuta, recent one, 64.3%. And then untreated hypertension was identified as the leading cause of heart failure in Abuja, Nigeria. And that is the reason why we can include this in our health campaign. When we have a day, we can include Operation Measure Your Blood Pressure as a campaign. And also, we could take this down to the hinterland to help our population, and then that go preventive, and we will be able to manage heart failure right in time. That's still the picture again there. Okay, now for another one, I've told you a lot of things today that you should not miss out. See where my cursor is. Jugular venous distension. I said it's in which type of failure? Hello, it's in which type of failure? Jugular venous distension. We there?
Right-sided.
Which side? No. Is it left side?
Yes, sir. We're here.
Jugular venous distension. I said you will see it which side?
Right side.
Okay. Please don't miss all this. I deliberately brought them out for you to pick it, despite the fact that you are far away. That at any point in time, you will not miss out any of this. So we move on. Of course, they will be on a different type of courses. I've told you about the courses. I will not overlabor that again. You see the picture.
Jiya na kira shi ya ce babu sai an kawo yau. Price ɗin ya ce.
Okay, heart disease, heart valve disease is there, hypertension is there, blood clot in the lung is there, diabetes is there, and severe lung disease, COPD could be a causative factor, obesity could be there. And you see in all these conditions too, we have our own role to play as physiotherapists as a preventive way, so that our patient will not land into the issue of heart failure, whether right-sided or left-sided. So these are different kind of ones, and the kind of damage they can cause from there. The one of vascular origin, we can cause aortic stenosis, mitral regurgitation, tricuspid regurgitation. Then the one of arrhythmia, we can call bradyarrhythmia or tachyarrhythmia. Then still talking about risk factors in a congestive heart failure. It can happen at any age and affect both sexes, so nothing to fear, though men often develop it more than women, and that probably may be linked to their inability to take good care of themselves and then pursuit of many social things like that. So chances of developing heart failure actually increases in 65 years age and up. And also by now, you should be able to pick from what I've said today that, of course, that has to do with aging factor, which leads to the stiffening of the heart muscles. And when the heart muscles are stiffened, you know that there's plenty work it has to do to be able to do its preload and afterload. So then the gene factor should not be surprising to you with what I've taught today. And then the risk factors of smoking, salt and fatty food, inactive lifestyle, alcohol, of course, is there, and also drug use. Situation that can be there. And of course, you also know that other conditions, COVID, we played with about 5 years ago, or there about 3-5 years ago. We know it played so significant role too in the issue of raising this. And people that are presented with this, we know how the mobility issue was there. Of course, we are living in Africa. The issue of income, the issue of education, and geographical region is also key. Now, the symptoms, take note of this again. The symptom depends on the affected side and the severity. Please take note of it. The symptom, it depends on which side is affected. Is it right? Is it left? It depends on the severity. And most symptoms are caused by reduced flow to the organs. They don't get enough thing to do. Fluid is built up in the body. That's why you see the bloating. That's why you see the swelling. That's why you see the edema. And this is due to reduced too slow blood flow from the heart or through the heart, and the blood vessels too, they blood build up there, and then it cannot be returned to the heart, or return to the heart, it's not going out. So also there's leakage. The small blood vessels may leak fluid and collect in the body tissue, resulting in edema. It's like sipping. Permit me to use that word, sipping of the fluid through the vessel, and then causes edema there, the tissues where a plaque is set. Now, what are the symptoms again that we need to see? Of interest to us as physiotherapy, the shortness of breath. And you now see the reason why we threw up our RP the other time, rate of passive exertion. Is very important for us as physiotherapists as we do our assessment for baseline and for monitoring of the patient. Stair climbing become an issue. You see some categorization I'm going to give unto you now. Two classic categorization I would not want you to ever miss. Please keep it as a treasure. Continue to practice it. When you come across such a patient, you begin to see it and do the scoring. You can even reconcile one to the other to know how it corresponds with one another. Then there's issue of fatigue and weakness, even at rest. And of course, when you get into at rest, when you go to, there's something they call New York Heart Classification. That one was developed as far back as 1968, but it's still relevant now. You see that as actually, you can use that, but when it's getting to that level at rest, I think it may be getting to class 4 or so. We'll see it very soon in subsequent slide. Of course, there's cough, which may be dry, which we have to work on. There's swelling, weight gain due to fluid in ankle and lower limb, sleeping difficulty for the person when lying flat. And so that's why modified Fowler position may be hit. The person will not be comfortable in lying flat at all, and there will be sleeplessness. Then nausea and loss of appetite, and of course, we have to take interest in all this as we manage patient, because if there's energy, there's no energy base to support our intervention. How would they cope? How would they continue? How would they be able to sustain it? So we should be interested in all this. The appetite, we do that in all the history taken and monitor subsequent to, and also trial with the dietitians on their management, and also see whether our patient is coping with it, so that they're able to go ahead with their physiotherapy. There's swelling in the neck veins, needing to urinate often. Those are the things that are seen there. You see the picture for man and for woman, their presentation has actually been conceptualized, put in table there. I've gone through this pathophysiology for you to actually have a better thing grabs when you are going through it. Now, complications now. Breathing difficulties can be there. And that's why of the measure, strong measure, either in respiratory problem, in cardiac problem, is breathlessness. It's also looking at. And then there's something we call WOB capital. That's a work of breathing. It shows ideally, when you are breathing now, you're in a course now, you're in a workshop now, nobody's hearing you breathing. By the time your breathing becomes noisy, it shows that your work of breathing is much. But when at rest, nothing at all, your work of breathing is little, it's minimal, almost zero. But in this instance, the work of breathing is increased because of breathing difficulty. Then there's a renal damage, kidney damage. We have traced, today we trace heart-brain connection. Now, there's another thing that could have actually been traced, renal-heart connection, because about 25% thereof goes to the kidney. So that's why it goes, and that's why you see some of these patients too, they can be managed in this climb of practice. The malnutrition, the loss of appetite, digestion, other conditions like irregular heartbeats, sudden cardiac arrest, and pulmonary hypertension. And now you see there now pulmonary edema. This is the LV alveoli in the lung, the alveoli in the lung. Now, when there's a pulmonary edema, it becomes swollen. It is those pores that are there, it becomes swollen. And when you begin to listen to the lung, you see some pop sound there. So the fluid build up in the alveoli and the alveoli. Once it build up in the alveoli, it begin to seep. Let me liken this sipping to you put your water inside a bread nylon, that transparent nylon, and you didn't know that a portion of it, there's a tiny hole there, and the water begin to do out. That is what happened from the alveoli into the lung, and that's why you now see pulmonary congestion. Now, there are stages. Please have to take note of this again. Finally, you begin to diagnose, you begin to see, this one may be A, maybe B or C. Now, this is what we call ACC or AHA heart failure stages. They are stage A, B, C, and D. Well, the issue of what do you call it too is also very significant here, ejection fraction ratio. But let's move on. In stage A, there are risks of heart failure. There's no symptom. There's structural heart disease or evidence of elevated cardiac biomarker. No symptoms of that at all. That is stage A. But the risk factors are present. Those risk factors I told you, they are pointing to it: hypertension, diabetes, metabolic syndrome. But structural changes, no. But when you get to stage B, where they call pre-heart failure, the patient begin to have signs and symptoms. So if I want to throw up a sort of a class scenario here now, begin to throw up some questions to you now, I seem to have seen a patient which begin to have signs and symptoms of heart failure. What stage will that patient be? Expecting an answer?
So, what do you say?
Okay, now let me go over it again. I said, so I've come across a patient, one Mr. blah, 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 say 69-year-old. He seems to be showing signs and symptoms of heart failure. What stage will he be according to ACCHA classification?
Stage C.
C. Good. There is structural heart disease. Structural heart disease. Now, stage D, patient with refractory symptoms that interfere with daily life and recurrent hospitalization. Okay, let me go over that situation. 69-year-old Mr. Blah, 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 blah has had about 8 admissions and is spotted to be having chest pain, features of the swelling, and co. Which stage will he most likely be?
D.
Okay. D. We are flowing. Okay. That's what I've put here now. These are very colorful one. Stage A, no symptom, heart function is normal. Stage B, heart function has decreased, but no symptom present. Stage C, symptoms begin to appear, such as shortness of breath. Heart function is decreased. Stage D, heart function is significantly weakened. I'm sure everybody can pick this. Is that?
Yes, sir.
Okay. Now let's now look at this now. Now, I've discussed the left side part of this slide I've given on to you now. I want to now talk about the right side of it, even though I mentioned it along the line. I call it NYHA is New York Heart Association Functional Class. Now, it has to do with class 1, class 2, class 3, class 4. Now, class 1 is asymptomatic, no symptom. In that instance, class 1 on New York Heart classification can correspond to A or B. Now, class 2 is symptomatic with moderate exertion and symptomatic with minimal exertion. So 2 and 3 can actually correspond to C on ACC-AHA. Then class 4, I talked about this about 10 minutes ago, that it is actually possible for somebody to have symptom at rest. That was the first time I introduced you to NYHA. That when the patient begins to have symptom at rest, that can correspond to D on ACC-AHA, because the person begins to have refractory heart failure, which needs specialized attention, intervention. Is that understood?
Yes.
It's okay. Thank you. So I expect that anywhere I meet you, I should be able to ask you this, you should be able to answer me. And now let me throw up a question for you now. I want you to do classification based on ACC-AHA and NYHA. Mr. MZY is an engineer who works in a factory and is presented with long-standing issue of chest pain, repeated admission, and inability to cope with his work, being in the third floor in his factory. Can you do the categorization of his heart failure?
Yes, sir.
Do it and let me know. What is the categorization?
He is at stage D in ACC and AHA, while in NYHA he is at stage 4.
I hope everybody got it too. It's okay. So our physical participant too got it. So we have good understanding of it, isn't it? Now, the ejection fraction ratio, I've told you about the preserved, the reduced one, the mildly reduced one, and the preserved one, and the improved ejection fraction ratio. Please don't forget all this. Very, very important. Now, in some instances, there's a modification of the New York Heart Association functional classification. The theory there is divided into almost like 3 again. When you go to class 3, there's symptom onset with minimal activity. 3A, no symptom at rest. 3B, recent onset of dyspnea at rest. But you can still stick to the one I've given unto you. But if you want to be more elaborate, you can say class 3A or class 3B, depending on how that exertion is bringing up symptoms for that individual. Now, for the diagnosis, of course, I've gone through this, but let me just take note of this, that one of the major criteria and minor criteria, notable under that minor criteria is also the pleural effusion, which is one of the things that we go through as a physiotherapist. This is the corresponding of the two together, the AHA, ACC, and NHA. So I leave that one because I've gone through it to help you. Now, possible relevant investigation, blood test, radiograph, echo, Doppler ultrasound, abdominal ultrasound, they are there. Of course, the presentation we have for patients, you notice that these tests are very relevant. You ask for it, you look at it, and you guide you in also your decision making there. So treatment of congestive heart failure now, we begin to step up our game now, and I want you to be very, very attentive here now. The goal of therapy for chronic heart failure is to improve symptoms, to improve symptoms and quality of life. Don't forget that. That's why you see some of the outcome measures we throw up there. They have to do with the activity of daily living of the guy. How to do with how to improve the quality of life of that person, and also reduce the hospitalization and the cardiac mortality for the patient. So anything that is done, we focus towards this direction. All these treatment you see that are packaged there, they are for, and sorry, let me also add this to you, is stage by stage. In stage by stage, they attend to their presentation. Stage A will be different from B, will be different from C, will be different from D. And that's why you may cast your mind back to people you know, or people that have the patients that have passed through your climb, passed through your system, passed through your hand, or directly that you are managed. That is the reason why you see them taking one sort or the other, because they are, that is what their condition actually necessitate at that particular stage. Now, we need to take note that stage G by now, you will know from what we have discussed that it is advanced heart failure. It's advanced heart failure. Of course, that will need referral to specialists, to heart failure specialists. Very, very important. There, specialists who manage them, specialists in the different field, cardiologists who manage, specialists in physiotherapy who manage, specialists in a different set of professional manage them. They will have to be there because it now needs a lot of attention. And the goal of care should be decided by shared decision making, which include comorbidity condition, frailty, socio-economic support. All this will be taken into consideration. Palliative care should be offered as indicated as part of the shared decision making. So this is the kind of prescription that is given to each of the conditions here now. Stage A, I want to relate it to the issue of the heart failure, the at risk. Stage A, stage B is heart failure, Stage C is symptomatic heart failure, then stage D is advanced heart failure. Another way in which you can use to explain this out, apart from the previous explanation I've given. When you notice anything say advanced, definitely know it's stage D. When you say symptomatic, know it's stage C. When you say it's B, it's stage B. When it's at risk, it's at stage. And this is also explain it out further. The other picture that you see, of course, the medication. When it's begin to get to, well, when it's stage A, the risk for modification by lifestyle can attend to the patient. Risk factor modification can be done with and used as a treatment intervention to manage the patient. Now, from stage B, there is intervention that is added, like medications and surgeries, which you should be interested in here. If time permits, I will play some video for you that you see there talks about this kind of stuff. Then, when they begin to get to stage C, but most especially stage D, you have multidisciplinary intervention for you to be able to optimize disease progression. Of course, these are the drugs that are taken by the patient. You have the lisinopril, you have the beta blockers, you have the calcium with the nifedipine, the ferrapine, you have the cardium glucoside, the digoxins too. You have the diuretics that are taken. The issue of diuretics should not be important, should not be strange to us, because I told us about possibility of fluid retention. Of course, in severe cases, you see some referral coming to you called CABG, CABG. CABG is coronary artery bypass grafting. One of the ways in which this is done, managed. Then you can also be heart valve repair or replacement. I told you about the procedure that I go through when I went outside for my specialized specialization training. Yeah, I told you that the guy had mitral valve replacement. Yeah, so these are procedures you should be interested in. This will be cost of referral to the department. The diagnosis, they will come. Of course, you will do your own diagnosis, physical diagnosis after you manage. But these are the classical things that you are going to see there. Is coronary artery bypass, mitral valve replacement, heart valve repair or replacement, the implantation of some devices you will see there. Then the physiotherapy treatment now, as we begin to custom there, in this instance now, will be to there are guidelines that have been developed. Physiotherapists will work collaboratively with other members. I told you from stage C down to D, there will be calling for multidisciplinary attention. So we work collaboratively with other members of the healthcare team, implementing the guidelines, and the guidelines will be able to improve the activity of the patient participation. Please let me say at this stage, even though you encounter in the few slides left for us to discuss, that no, because of this condition, the patient will not be left alone to become inactive. You are giving the patient death sentence if you do that. The only thing is to understand the condition of the patient and begin to moderate the intervention. Leaving the patient alone is like promoting stasis. No movement of blood. And you also know that when a muscle is not working, what happens to the muscle? It becomes weaker. The same thing happens to the heart. The heart is just sleeping there, it's not working, What happens? It becomes weaker and weaker, and it begins to complicate the issue of heart failure that is already the heart become weaker and not be able to do what it's supposed. So we have physical therapy clinical practice guidelines for the management of individuals with heart failure developed in 2020 in this respect. Also, there is medical evidence on the effectiveness of a variety of rehabilitation treatment interventions for patients with heart failure, and this actually continue to evolve. People do more work is coming out for there. But something basic is this: physiotherapy is needed. The dosage can be tampered with depending on the stage it is, or depending on the class that it is, whether it's unusual class vibration. I see interventions like education, very important, patient education, the start exercise, we talk you, it's important for the patient, it's documented, it's been researching. Aerobic exercises, even very common, particularly in the world. I'm going to show you some video. You see a patient that was managed with cardiac surgery. I think it's 2 weeks or 12 weeks after. You see the picture of the man doing very well, even on the recumbent bicycle. The inspiratory muscle training is there. I told you that the respiration will be affected because of lung inactivity, and because the lung is not put to optimal use. The inspiratory muscle are not contracted very well. They will be weak. There's what they call IMT, inspiratory muscle training will be done. Of course, electrical stimulation, behavioral modifications is there. Also have this intervention we talk about in physiotherapy will help to improve the functional capacity of the patient. You have to improve the strength. You have to improve the quality of life of the patient. I'm shocked with that when the patient go back and do the echo, it will surprise you that the ejection fraction ratio will be better. These are things that I've seen in clinical practice. I've seen it. I'm reporting it back onto you, things that are monitored there. Then could also contribute to decrease hospitalization of the patient. Now, look at this now. If you look at New York classification, this slide 180, you see that in class 1, the exercise that can be given to the person will be greater than 7 MET. MET is metabolic equivalent of task. There's a way metabolic equivalent of task is associated with each task. There's an activity, it will shock you that even sitting has its metabolic equivalent of task. I'm not sure, it may be one metabolic equivalent of task because work is being done. So when you look at this picture very well, this is advanced prescription of exercise. In the management of cardiac condition, you see the physical activity that can be performed without discomfort. Somebody in class 1 can do jogging at 8 kilometers per hour and climbing stairs. And when the person is on class 2, the person can walk at 6 kilometers on level ground, and then the activity will be between 5 to 7 metabolic equivalent of that. I want you to take note of this. As the disease advances, the metabolic effect of task for the work to be done drops. Have you noticed that? Have you noticed that? Yes. So as the class increases, classification of the heart condition increases, the tasks that are supposed to be done by the patient reduces. Have you noticed that? Yes. Like in class 3 now, the task is 2.5. Don't forget that we started from greater than 7 metabolic of tasks. Now we are now in class 3. The activity that guy should be able to do should be between 2 to 5 metabolic equivalent of tasks. Now when he gets to class 4, which is advanced, the guy must do something like less than 2 metabolic equivalent of tasks, because the guy will be having symptoms when carrying out any physical activity. So you don't bombard him with things that we can call more symptoms, but you don't leave him without attending to it. So is that picture for you there? This also one thing you must not forget. I can always ask you anytime I meet you. Everything has to boil down with the physical activity. And you can now also begin to see the relevance of the step that we have in our physiotherapy department, that we have in our gym. You see it now being becoming used to. So definition of zone color associated with clinical manifestation and physical therapists are recommendation. There's also this color issue that is used, it's called zone color in prescription and co like that. When there is green zone, the signs and symptoms, there is no shortness of breath, there is no swelling, there is no weight gain, no chest pain, there is no decrease in your ability to maintain altitude. Let me ask you, this green zone, with all this I've said, which class do you think it will be? Stage what?
Stage A and B.
Stage A. Most likely stage A. Well done. So the physical therapist recommendation is continue activity and therapy as tolerated. Then yellow zone now, there's weight gain, there's increased cough, peripheral edema, increased shortness of breath with activity. Which stage most likely will it be? Yellow zone.
Stage C.
Stage C.
Good. What are we supposed to do as physiotherapists? Symptoms may indicate an adjustment in medication for warrant communication with physician. We should be able to also carry our patient about that. So as they continue our therapy for us, and as we decrease the metabolic equivalent of tasks of our prescription, we should be interested in whether they are going for their medication or not. Red zone. Red zone. Read the red zone and tell me the stage it will be.
Stage D.
Okay. Of course, you get it from the mnemonics. Anything red is what? Anything
Danger.
red is what? Danger.
Danger.
That should tell you is stage D. And when you go to New York Heart classification, what will it be?
Stage 4.
1, 2, 3, 4.
Stage 4.
Stage 4.
All of you got it, both physical and also virtual. You got it. That's good. So symptoms indicate over the compensation and an immediate visit to the emergency department. And you now see the reason why I gave you some outcome measure in ICU critical setting. there now. There may be need for hospitalization there now. So that's that. And now our intervention, these are the physiological rationale behind it that you can throw up in case somebody say, and you say you are relevant in the management of a heart condition. What is he going to do? He's going to help you. We are going to help the patient because there will be physiological adaptation to the exercise training we are going to prescribe. But I've already agreed that the exercise dosage will be depending on the condition in dosage like that. The VO2 peak will improve, and also as it improves, the stroke volume is going to improve. And once stroke volume improves, it's going to optimize arterial oxygen, it's going to optimize oxygen delivery, which are factors that can compromise in heart failure. Also, there will be increased exercise tolerance for the patient. There will also be increased oxygen extraction. When there is increased oxygen extraction, what happens to the muscle? The muscle also works very well. The patient will be able to carry out more activity. He will be able to get more exercise tolerance. There will be incentive for more performance. The skeletal muscle will not waste away, and the cycle continues end and end like that. So we are what? Relevant and relevant. But we need to note, these are the done to compare high intensity to moderate intensity. And it's been shown that it will surprisingly shock you that, of course, even though it could be challenging and intimidating, it will surprise you that high intensity training actually will produce more result than moderate intensity, even though you do it with caution. It means that more work is expected to be done in that instance, and that's why that is stated that way. But you continue to monitor. These are meta-analysis that have been done. These are systematic review that have been done in many instances that show that we are actually relevant. The high intensity interval training is significantly more effective, like I told you, more than the moderate intensity for improving the VO2 max. VO2 max, maximum oxygen consumption is the gold standard of fitness. There's some formula to compute it, but the issue is that it can also be, in most cases, it is done under laboratory conditions. And then, of course, the left ventricular ejection fraction, left ventricular failure also going to be improved in the process of it. So these are practical guidelines of what's supposed to be done. Whether there is aerobic training, resistance training, inspiratory muscle training, the dosage of it, I've given you here what can be done each particular time. The frequency, 2 to 3 times weekly for aerobic, the intensity, patient operating between 40 to 50% performance. Of course, this should not be strange to us now. How you get that is this: you 220 minus the age of the individual will give you the first figure. When you want to know the that's maximum heart rate. When you want to know the target heart rate now, you go for the percentage. If you want to do the 40% of it now, you now do 40 over 100. That is 0.4. 0.4 times the maximum heart rate will give you the target heart rate for 40%. You do that one for 50% too. That will make the patient to operate between 40 to 50%, and you monitor like that. Well, if you have you can plug the pulse oximeter directly, or the heart rate monitor directly with the patient, as he or she is doing. You continue to monitor, and of course, even some bicycle ergometer like the video I said I'm going to show to you. You have a sophisticated system, which of course is what I prescribe for us, a sophisticated bicycle ergometer, whether recommend or standing. You can continue to monitor this. There, of course, such patient cannot be left alone. You will be with the patient. So resistance training too is very, very important. As you can see here, the weight, resistance handball, TheraBand, to the patient. Also, inspiratory muscle training, like I said there, that will be standard protocol is 6 to 7 days a week, twice daily. In fact, I subscribe to this. That's my recommendation over years for this, because it's not something that will be done once in a while. It will be done throughout the week. In fact, some instances, I want it 3 to 4 to be done for the patient. These are some harmful effects of sedentary behavior that are seen in some individual. Now, it has to do with cardiac, it has to do with physical level. Now, sedentary, this is a study that was done for sedentary group that are less than 10.6 hours per day sedentary. Then there's a sedentary and active group, which is also less than 6.6 hours per day in activity. We discovered that 50% increased risk for people that are sedentary. That's why I told you it's a misnomer. It's a sorry to use this sort of sentence. If you don't allow the patient to do things, we should not be too afraid not to allow the patient to get things done. It's that on its own is a misnomer. The patient must do. It's only that we must moderate. I've told you there's high intensity interval training, there's a moderate intensity. High intensity produce more result than intensity. But you now see here now that is combined with active group, that person the risk up there. So we don't want sedentary nature. So good activity reduces risk. One of your take home here in the management of cardiac condition and also the management of heart is that there's 15% greater risk of heart failure when there's when there's excessive sedentary time. So there's 33% higher risk of cardiovascular disease and mortality when this issue of sedentariness is increased. The more sedentary the patient is, the worse the condition is going to be. And these are the benefits that have been shown in studies that have been carried out in the cardiovascular rehabilitation, which shows the importance of our intervention. Now, this is the way you go about it. You want to summarize the treatment protocol for us as physiotherapists. We do the history taking, like I told you, do the assessment, particularly activity level or the current problem, the assessment of the health status of the patient, the cause, the prognosis, the other information, the social one, the examination of it. Don't forget, we'll do the assessment of the impairment, activity limitation, health problems that may influence the choice of exercise you are going to give to the patient out of the law that I've given unto you. Then you analyze all this. Is a focused attention. It's a focused treatment. The B1 is not for A. The A1 is not for B. It's not what is meant for patient A is not going to be for B. It may look similar, it may not be complete because it's specific goal. And then you do your specific goal, you do your general goal, and you monitor from time to time. This assessment I've shown to you, you will be able to pick that one from time to time. You should be able to do that one by yourself. What is the prognosis? Now, according to CDC in America, that's Center for Disease Control and Prevention, in 2015, the rate of heart failure related deaths decreased from 103.1 deaths per 100,000 population in 2000 to 89.5 in 2009. It decreased, but subsequently increased to 96.9 in 2014. This actually can be attributed to the fluctuating issue of our physical activity. That's why we cannot underestimate. Of course, you also do during the COVID era, where there's a shutdown or lockdown on the lives of there, when there's, of course, many studies reported reduced physical activity. If you go back to this now, trace out some figures concerning it, you will notice that it's possible that the mobility has actually increased during that period. And everything traceable to the lifestyle of the individual. So, early treatment, good result. But when it's not done early, then something else will happen. Well, there is one of the interventions we can adopt is continuous positive airway pressure as part of our cardiac rehabilitation in patients with congestive heart failure. This is a case report that was done that can be learned from. It's a case of 51-year-old female patient. Then it was on New York Heart Classification 3 without any musculoskeletal pulmonary comorbidities. And then good results in there. Sin et al. 2000 and Whitman et al. 2000 previously also indicated that this continuous positive airway pressure can be used as adjuvant therapy. That means in addition to some other aerobic and co, it will improve the cardiac and pulmonary function of it and relieve the symptom of cardiac heart failure. Of course, there are many things to use to explain this physiologically, just the way I've told us before. The training protocol is 4 times weekly session for 6 weeks, and then the continuous positive pressure too was applied to the airway during the entire session. Then the training consisted of aerobic activity of treadmill or bicycle ergometer. The bicycle ergometer, of course, you can't be in a cardiopulmonary setting. I don't have your bicycle ergometer, don't have your treadmill. These are instruments that are very very, very important that you have to use. And I suggest they must be well calibrated. Of course, we see the improvement here, there, and you now see that the Minnesota questionnaire that I gave you earlier on, which has to do with question quality of life, is not strange. You see it being used in this study. You see it now that the ejection fraction ratio improved from 33% to 36%. The oxygen consumption by the myocardium 2 are actually improved, and the patient dropped from New York Heart classification 3 to 2. That's to show to you that when we intervene, we'll get good result. Look at the 6-minute walk test. The distance cover from 152.45 meter, it increased to as much as 520. That means the patient is getting well and the patient is ready to go back to his life. Now, well, these are some basis for our intervention. Cardiac oxygen demand, which has to do with the amount of work that is performed by the heart per unit time. All these are the indices that is going to improve when we treat our patients. Now, myocardial oxygen consumption too will be positively affected. Sorry, I hope I'm not going back. Okay, the clinical significance of the continuous positive airway pressure there is an increased intrathoracic pressure. It's not just a machine, it's not just a modality, it's not just one of those things. It decreases the preload and afterload that I taught us of. The transmural pressure in the left ventricle decreases, and that will now increase the stroke volume and outward flow. So there will not be congestion there. And that is the continuous positive airway stuff we have there. We have the BI one, we have the CPA one there. These are modalities that we can pick and we can use. This is the way it's fixed. These pictures are deliberately put here for you to see the procedural way of fixing it one after the other to help the patient, how it is one after. And you see, these are handy equipment that can be gotten for our place. Also, when there's an intermittent claudication, which is part of the domain of cardiovascular assessment and also treatment, according to this NICE guideline. NICE is National Institute for Health and Core Excellence. Most of the time you'll be hearing NICE guideline, NICE guideline. NICE is National Institute for Health and Core Excellence. They give some guidelines from time to time. During those COVID era, they give a lot of guidelines. They are still in the process of giving the guideline here and there. This particular guideline is given for intermittent claudication. And intermittent claudication has to do with muscle pain or discomfort during walking, which can be caused by narrowed arteries. And don't forget, I talked to you about plating of the arteries, which reduces the intimal layer, the diameter, and the blood will not be flowing very well. It causes problems. So walk regularly for exercise has been shown to be very good and shown to help better. That habit will help. It reduces the pain, it reduces the need for any vascular procedure, surgery, or the like. It improves of course, the heart function and vascular health. It improves the mood of the guy. It will be able to sleep very well. There will be healthy weight for the person, and the patient will also begin to improve in terms of function here and there. I want you to listen to this. Fine. Okay, let's move on. Sorry. No. Sorry.
The video is not audible. I didn't hear anything.
Okay. You didn't hear it too?
Yes.
Yes, the video is not audible.
Okay, you didn't hear? Okay, I will go over that again. Sorry. Okay, come on. Can you hear me? Put the volume. Just a minute.
Still not audible, sir.
Maybe I will jump the video. You will see it in the slide. It will be passed across to you. Let me just jump the aspect of the video. Maybe it's, but you will, because it's playing here and I'm hearing. When you have it, you'll be able to play it. You'll be able to understand and bring in some practical perspective into what I've been discussing with you. So, let's play this one. No, it's okay. It's okay. No, it's not good. The volume is down. Can you hear it now? No, you press something. No. Sorry, you will get it in the slides, you will play it on your own. So now, for us, as we treat this patient, some of this procedure I told you, you can see it now in the screen. As we strap it, there will be need for suctioning when there is a chest congestion in some instances. I will also play this one, even though you will not see the video, you see some of our procedure. Even though you may not hear what he's saying, you can see the procedure. Please don't underestimate. Some of us believe that it is until you use machine that the patient can get better. This man now, this is not in Nigeria client, this is overseas. He's doing his maneuverings. the passive movement. I will play it again. The passive movement, the assisted active exercises for the patient. Don't forget, the aim of it is for blood flow, is for activity. See, now this is not machine, even though in some instances there may be need for continuous passive motion machine in our ICU. But in instances where it's not there, go ahead and do your passive movement. Don't underestimate it. I keep saying paracetamol or PCM still has its own relevance in management. So our PM, passive movement, still have relevance in the management of patients. Let's do that. Let's learn from this. This is from overseas, it's not even from our client. And this patient is getting better. I'm going to show you more video, even though you are not hearing what they are saying, but you pick the picture from me. See the passive movement, full range movement, and that preserves the physiological properties of the muscle, prevent contracture, ensure there's blood flow, and also challenge the heart. Don't forget, I said you that you'll be doing a disservice to the patient if you just leave the patient alone without doing anything. So look at this now. 2 months ago, this person was diagnosed with stage 4 heart failure. See, let me play. Can you imagine? Can you see? I think you can see this and you are appalled that we can do something. Stage 4. So we move on. Let me look for another one. Okay, now this has been scrappy for the lung. Some of them that might have chest congestion. Yes, once there is no PE, you go ahead and do this. It will help the patient. It will dislodge the secretions, and the patient can cover. See the ringing there. See the shaking. Can you see the exhalation and off? Oh, Then yes, assisted breathing now by herself, self-assisted. But don't forget that the end process here should be expectoration. The whatever is there must be brought out by the patient. Okay, see this another one. Let me play it. See her using the TheraBand. Don't forget, I told you there's growth for resistant exercises. Doing by herself, aerobics. And this is inside our ward. She's usually feel tired before. Fine. Let me see whether I can still pick one more for you. Yeah. Okay. This elderly man. Now see the tandem working. Don't forget the short battery protocol I gave to you. You now see that these are things that are relevant in this climb that we may not know. See now. Let me pick up more. Deep breathing exercises like smelling the roses. Overhead protein and readiness. I want you to look at where. Let me play the two for you. This has to do with it's a cannulated procedure that can be done for the ventricle to help the heart. Like when it's so diagnosed and be discovered that the heart is so weak, can't go ahead again, they put this inside. And that's why when you see any surgical incision on the chest about those intercostal spaces I've told you, from second to the fifth or sixth, begin to question, was any procedure done there before? So let's go to this man that had surgery. Now. Twelve weeks for surgery. Fine. So would you be out some other interesting one that can help you out? Now, let's look at this 1 month post-heart surgery now. I've taught us about the 6-minute walk there. See this beautiful runway. Yes, I've told us about the relevance of resistance exercises about 3 times a week. Fine. It's been a long day. We've been together. I'm sure you've learned a lot of things as I begin to round up within the next few minutes. Now, the point is this. As we conclude, heart condition and disorders, they are characterized with the loss of ability to efficiently pump blood to the extremities. The organs, the skin, everywhere didn't just receive what it's supposed to receive. And it's sort of a med needs, And that actually threw up a situation whereby the physiological requirements that blood and oxygen confer on those areas will be compromised. And once this is compromised, a lot of things begin to take place, which is a sort of the conditioning process. Now, there's a lot of hemodynamics that is altered, the neuroendocrine is affected, there's inflammatory issues there. Organs like lung, like brain, like kidney, like liver, and skeletal muscles, all of them, they are not spared. So the conditioning effects begin to take place affecting all these organs. And because we have physiotherapy, notably, we begin to see these things happening in the skeletal muscle of our patient compromised. That's why their mobility, they lost or gradually is compromised. And this is further compounded by a lot of pathophysiological changes and compensatory mechanisms that are put in place that begin to happen. Of course, their quality of life is compromised, as we see in a lot of signs and symptoms that they present, leading to substantial limitation in their physical function. And therefore, this shows the inevitability of physiotherapy in the management of this condition. Recommend that people living with predisposing factors should seek medical attention in time and be given prescriptions. And like I said earlier on, physiotherapy should go on health campaign, educating on this, on what we can do, also help our population. As we can see that most especially in our climate in Nigeria, hypertension have been responsible for over 60% of all this presentation here. There should be lifestyle modification. Sedentary life will not benefit anybody. The fact that somebody is employed doesn't mean that he cannot be sedentary. We have employed people that are still sedentary. We have people that just get themselves to the issue of recommendation of 30 minutes exercise 5 times a day, 150 minutes per week. But what do they do when they are in their office? They are not much into activity. There's what they call sitting syndrome, sit disease that is happening to people, precipitating on this condition. And then we must watch our diet. There should not be plaguing of our vessels. We must emphasize activity. Physical activity does a lot of good to the body. We must know that physiotherapy is actually engaging in the management of this condition. The only thing is to be able to diagnose appropriately, to know the stage according to the ACC/AHA classification or according to New York classification, to know whether it's stage A or B or C or D, or to know whether it's class 1, 2, 3, or 4 in New York classification. If you know, if all that is known, one will be able to know the right prescription based on the metabolic equivalent of tasks. But it needs to be said before I round up that the higher the stage, or the more the advancement of that condition, like in stage D, the less the metabolic equivalent of task for such patient. Thank you very much. The floor is open. I hand over to the coordinator for questions. Hope we learned a lot of things. Yes. I will still call him to be my model. I will show you those things I was talking about in intercostal space now. But let me ask questions, please. Questions, please. Are we together?
Yes, sir. Thank you so much, sir.
Pleasure.
Thanks for your intervention. Thanks for your presentation. You did well, sir.
Thank you very much.
So my question is, in case of arrhythmia.
Yes.
And at what point should we come in as physiotherapists to engage the patient in cardiopulmonary rehabilitation?
Yes. Well, the issue is this: once there is no extensive chest pain, once there is what do you call it? We have been able to do the appropriate diagnosis, whether we are the one that did it or according to the referral they gave to us. We will start with our small dose, but we must not do things that will increase the heart rate unnecessarily. We'll monitor it. You can start from low percentage target heart rate for the patient and monitor. Don't forget, and then once there is no issue of PE, no PE is there. we can go on those procedures. Don't forget, I said one of the warning I gave in this presentation today, in our course today, is that we must not, I won't use the word lessen sedentariness. We must not allow sedentariness for the patient.
Hello, sir.
So,
sir, sorry, my network went off. I didn't hear you.
Okay. What I was saying is this: say there is no chest pain if there is no established issue of any maybe pulmonary embolism for the patient, and then if there is no unnecessary fatigue that can make patient to even do some, then we should start on a gradual note with low percentage target heart rate for the patient and monitor the response with time.
Okay. Currently, the patient presents with weakness of one side of the body, but the patient presents with weakness of just mild weakness of one side of the body. Reduce the gait pattern has reduced.
Yes.
Yes. So currently, he's still seeing cardio. The patient is still seeing cardio, but she came for first contact. She came on her own, and that she feels that she needs physiotherapy. So what I advise is, since cardio asks for ECG, you should go for ECG. Let cardio let cardio assess properly, and the ECG came out and said there is arrhythmia. The heart rate is 46.
Okay.
The heart rate
is 46. Now, such a patient will be put on self-administered exercises, low intensity.
Yes, sir.
Are you hearing me? Are you hearing me?
Okay.
Are you hearing me? Yes, such
sir.
a patient will be put
I'm
on
hearing you,
self-administered
low intensity,
self-administered low intensity exercises. And you keep monitoring that. When there is improvement on that, you can also improve on the dosage of administration. More questions?
Sir? Hello, sir.
Yes. Did you get what I said? I said you put the patient on self-administered exercises, like free active exercises, just like what you saw in some of them. Free active, just movement by himself. Just things, movement by himself, but low intensity, operated at low intensity. But you keep monitoring on that. As that improves, that will also make you to also step up the dosage of administration of exercise you are giving onto that individual.
Okay, sir. Okay. Thank you, sir.
Yes.
Good afternoon, sir.
Good afternoon. You are welcome.
Thank you for your presentation, sir.
Thank you too.
Sir, hypertension is a common condition we usually see in the clinic.
Yes.
And I don't think we do enough, or we actually do anything as regards the management of hypertension. And it's very common. It's something we always see in the clinic daily.
Yes.
So I'd like to ask, what's the line of management? And when it involves exercise, what are the exercise specifics? What are the prescription? How do you prescribe exercises for a hypertensive patient?
Thank you very much. Well, the baseline, I know you know this already, the blood pressure will be monitored. What do you call it? The target, the maximum heart rate, the target heart rate. Pre-active exercises will help the patient. Resistant exercises will help the patient, but it's patient specific. It's patient specific. The blood pressure is too high, of course, definitely you may not be able to go into the extreme of resistant exercises. But if the blood pressure is within reach, you will go there and monitor the response of that patient to it. Definitely, I agree with you. A lot of people are afraid to go into it, but it's been proven. You can. It's in literature that we are so much effective intervention in the management of hypertension. That's my recommendation for you. I know what. But in instances, what we are dealing with may not necessarily be blood pressure alone. In instances whereby you have to check lung. You have to check lung. We must not be checking only the blood pressure. That's why when the patient comes, as part of the vital we do, of course, which is a takeaway from this workshop today, is that you auscultate around the lungs too. Has the lung been affected in any way, so that you know whether there's a protocol to administer to the lung. It is patient-specific, emanates from the examination you do for the patient. But free active exercises, resistant exercises will help the patient. Aerobics.
Thank you very much, sir.
Yes. But please let me add this. Let it always be a guided and well-monitored intervention, please. Not the person be on his own or her own.
Thank you very much, sir, for your presentation today. I actually have a question, and it's about the patient. An 82-year-old woman. She has background chronic congestive heart failure, and about a week ago, she
bilateral or left or right?
The heart failure.
Is it right or left or both of them?
Right now, I cannot remember. I just saw her just yesterday, so I can't really remember right now whether it was right or left. But she suffered stroke about a week ago, and as seeing her yesterday, her pulse rate is fluctuating between 60 beats per minute to it sometimes goes as low as 40. So I just and okay, then also they are also trying to do carotid artery Doppler, probably to know the cause of the stroke. So I just want to know such kind of patients, what position is best to, because actually when we are trying to treat her, we put on the pulse oximeter to monitor her SpO2 and pulse rate. Her SpO2 has been okay. Her SpO2 has been like 99, 98, 97, but it's just that the pulse rate is always dropping. So I want to know, not one, what's the best position to actually see that kind of patient? Should she be seen in supine lying, or I don't know, or maybe a little bit head of bed should be a little bit raised? And what kind of interventions can we do for her?
Thank you very much for bringing this up. Also, is fresh. I will not recommend, and see from what we said today, I will not recommend supine. The patient will not be comfortable. Go for modified Fowler, probably about 30 degrees prop up. I'm sure it's in a facility setting or at home.
Facility setting, sir.
Is it facility setting or at home?
Facility setting.
Fine. If you have that kind of electronic bed, just prop it up to about 30 degrees. It will be better for the patient. Now, I would recommend, just like you see in that video, I would recommend passive, I would recommend assisted active, but moderate, low. But we'll wait until the result of that Doppler is out. What is happening? You understand me? To be able to be on the complete safer side, you have not lost anything. Then you can put the patient through on some gentle breathing exercises, not the exertive one. Gentle breathing exercises, not the one that you are going to press by yourself, not the one that you are going to do percussion. Let them just to ensure adequate ventilation of the lung. And because you already know that because there is that failure, the lung definitely be affected. There are possibility of the risks of pulmonary edema and also pulmonary congestion. So that's what I would recommend. Please monitor the result of that procedure that want to be done for her.
Okay, sir.
Yes.
Thank you, sir.
Yes. Thank you very much. It's been a nice time being together. You have the slide that will be delivered onto you to go through. Please pick it as treasure. Hello, that you can always refer to it from time to time.
Hello, sir.
37 slides presentation.
Hello, sir.
Hello, go ahead.
Okay, please, I have this particular question. I think he's a patient, but I want to bring it up as a question so that I can actually know the exact intervention I have to give as a patient, as a physiotherapy, so to say. This particular patient has a right lung collapse. You know, as you say that lung, heart, and brain, all of them interchange. If there is a shortage or problem, a particular one is affect each other. So she has been complaining of a severe headache, mostly at night, that he used to wake up with that particular headache. Then we have actually gone for a echocardiogram, and he has been given some kind of medication, and those particular signs and symptoms have stopped. But currently, due to the sedentary lifestyle, I have noticed that the patient has been increasing in weight day by day, and currently is also complaining of I think also arthritis of the knee as a result of maybe a whole lot of weight that the patient is getting lately. So, but I don't know exact. Okay, each time I check the SpO2 is reduced. It's not. I think it's below 94. Below 94. Most times you get 90, 90, 92, 80, something of that nature. So I want to know the exact intervention one has to offer as a physiotherapy in this particular case, sir.
Thank you very much. Very, very good question. But I will first of all suggest something, even though it's a bit difficult. Whichever way you can get it done, you need to chart the BMI of that patient.
BMI, okay.
BMI,
okay.
yes, you need it. I know it may be a
Mm.
bit difficult. That's why I say it may be difficult, because I don't know whether she stands on her own. Does she stand on her own?
Yes.
Okay, then you can do your BMI. BMI
Okay.
it and begin to monitor it. Now, the SpO2, I want to suggest, if it's not let me done, chart it. Let's monitor it. Is it perpetually that is dropping? Has it ever dropped below 90? Is it and when it dropped below 90, is it just one occasion or two occasions? If it's not all that time, then something can be done for her. But the bottom line is that we must not encourage sedentary lifestyle for her. She must move. She must move.
Yes.
Is she walking? Is she ambulant?
Yes.
She's ambulant. Fine. Yeah. If it is only this little perimeter inside her bedroom, you can put the caregiver there, attentive caregiver anyway, to monitor. Let her cover about some perimeter inside her bedroom in a day. That is enough. That is enough metabolic equivalent of tasks for her. Is going to help her. And then that one now, you now build on it with time. As you notice improvement in those other parameters for her, definitely she must not be in sedentary. It will aggravate the problem for her.
Okay. Thank you, sir.
I hand over to the moderator. Thank you very much, everybody.
Thank you very much, sir.
Thank you so much. It was really in-depth presentation, and we thank you for all the knowledge you impacted.
Thank you, sir.
We thank all the participants as well.
Hello, good afternoon, sir. Hello? Hello? Hello.
Was it, are you on medication like that with it in or actually my mom come out of the women?